your coffee and some conversations to please take your seats because we are going to start in 2 minutes. Descansou pouquinho? Não. Curtiu o almoço? Só vai piorando, né?
Honor of having Professor Kursat here. He's not only the most experienced doctor in glue, but also one of the most experienced phlebologists in the world. By the way, he's a cardiac surgeon as well. And he's president of the Cardiac Society, a Cardiovascular Society of Turkey. The former president, he's here. And he had a lot of problems that could avoid him from coming, but he came because he wanted to be with us, he wanted to share his knowledge, and also he wanted to learn with us, and that's why what we are doing. I want to invite you all to go to Istanbul. I'm going to go to Istanbul. And like Sergio's meetings, is going to be fantastic. And it's going to be like this also, not only science, but a lot of social events, networking, fun, and something to remember for the rest of your life. I've never been in Istanbul. I've always wanted to go to Turkey, but time has come, and it's 2022. There is a booth outside so that you can get all this material, and also call for abstracts. If you want, would be a very interesting opportunity for us to show the Brazilian experience in Turkey. Well, also, I was president from the Brazilian Society of Laser in Medicine Surgery from 2017 to 2020. I went through the pandemic as well with the society through a difficult election. And in this society, you have not only vascular surgeons or phlebologists. We have dermatologists, plastic surgeons, OBGYN, gynecologists, and all sorts of, even orthopedics, all sorts of specialties. And that means when we go to the Congress like this, we meet doctors from their very different backgrounds. And as Marta Leonardi said, this is very important for us. Please, the light is, a luz está muito baixa, não pode, aqui não é LED. Pode deixar claro o ambiente, como estava de manhã. Yeah, because the LED is different from the projector because we need to have light, more lighting, like here. We don't need to have a dark and everybody's sleeping because of the projector. We have the true dark. If we put the black, is black because there is no light. Well, also I like to thank our partners, beginning with the Diamond level, the Iconi and Mindray, and also Amigo. Fab Inject, Sally, LBT Lasers, long partner. LBT Lasers did the first, organized the first congress with me, IMAP. Dr. Shehi, which is the the white coat that we use. Vidence Medical, also another Brazilian brand. There are 3 brands of lasers here, transdermal lasers. And also IMAP Academy, of course. BTG Pactual is the bank that was sponsoring the IMAP Academy session. Mercedes-Benz through McLarty Maya, a big dealer for Mercedes and other brands here in São Paulo. Por favor, não apaga as luzes não, é para ficar claro mesmo. Senão as pessoas dormem. Chili Beans, vocês entenderam ou não? Chili Beans. Vital. Vital is a laboratory that we use at the clinic to make exams. They have outside, they are sponsoring the ambulance, and also they have a special ambulance where you can have the newest release of flu shot. If you want to go there, I believe, I don't know the price exactly, but it's very cheap, and you can get the flu shot right there outside, or a COVID examination. And if you need to travel, also for those who need to travel abroad, they can do the COVID test in that place as well. Bauerfeind, long partner since the first IMAP. TechMedic as well, with the endovenous laser. We are going to present today 2 endovenous laser from broadcasting from the clinic with the Hemocat group from the vein viewer, and also Sigvaris and Philips. Well, thank you everybody. Thank you for the organization as well. Our team was amazing, and they could handle me because I'm a little bit crazy. And let's resume the session now.
Thank you, Dr. Kazu. So, as he said, let's resume. Welcome back from lunch. I hope all of you have enjoyed your lunch and the conversation with the friends, and that you are now recharged for this next session, which is going to be a very important session to all of us. Important for a couple of reasons. The first one is that it's going to be moderated by one of the most honorable guests that we have in this room this afternoon, who's Dr. Sergio Gianesini. He's a vascular surgeon and a professor at the University of Ferrara, Italy. Also, he's a professor at the Bethesda University in the US. He's also the vice president of the International Union of Phlebology and the president of the VWIN group. So the second reason why this is an important session, it's because it's a historical one. And he himself is going to tell you why. So enjoy the session. Professor.
Thank you so much, Larissa. I feel like an assistant of Larissa in this moment, so I will need some assistance as well, because this is, in reality, a joint session of IMAP and VWIN. And as always in VWIN, we say it's not just where you're going, but also whom you're traveling with. And of course, the heart is pounding being together again in this trip. So I either need either Kazu or another Miyake family member or Bono or somebody to share this moment that is quite historical, because indeed this session is including 16 world-renowned experts as discussants, 4 per continent. So it will be really an attempt to fill the gap, that is the acronym of the session, Global Aesthetic Phlebology, because I truly mean it when I say that it is a gap in our culture as vein experts if we don't attend IMAP at least once. I really mean it when I'm saying worldwide that this is a meeting everybody should attend at least once to be inspired, as we were this morning when the session started, really touching our hearts after such 2 years of difficulty. So I'd like to deeply thank Kazu. I don't know if you want to say a word about this session.
Hello. First of all, thank you for everything. We were discussing this in Dubai in your wonderful event. I try to don't miss it. I missed the ski one. I couldn't be there, but I always try to be, and I always want you all to come every year. We do our best to help you. And this session is really important because it's an international session, and this will help us to open our minds and see the opinion of world leaders from all over the world, literally. And let's go.
So the way it will work is that we will have 4 talks on met and unmet needs in aesthetic phlebology. We will start huge with the master of aesthetic phlebology from Canada, Pauline Martinbeau. And then we will have for each and every talk 4 discussants, 1 per continent, talking about CLACS and aesthetic phlebology in general to understand how together we can be better in the management of aesthetic. That is indeed the highest form, I would say, of phlebology. I think that the main gap over here, culturally speaking, is that spider veins are not just small things to be done to some private practice. It's actually the highest form of phlebology because it really requires the knowledge of all the system, for which we have a true system of experts that is with us today. So we'll start from Canada with Pauline Martinbeau talk. You should
Dear
have already
friends, it is a pleasure for me to be here opening this event together with friends and colleagues of high scientific level. For many years, IMAP has been representing Latin American phlebology in the world, and now the Big Wing has the opportunity to accompany this event that for sure will not disappoint you. I take the opportunity to congratulate the speaker and greet the audience.
And indeed, this is not Pauline Martinbeau, as you can guess. But
Good morning,
since,
good afternoon, good evening. Welcome to the IMAP VWin joint session at IMAP 10. I want to congratulate the organizers for hosting such a robust scientific program. Please enjoy. Thank you.
this is indeed a wonderful surprise, reminding us how it's always about teamwork. And indeed, you have recognized Professor Bottini from Latin America and Professor Youngwei Chi from University of California, Davis. Professor Chi is as his house over here as well, on behalf of the WIN Foundation. As I would like to have also Felipe one day to join us over here, because I like first of all to have an applause for Felipe, if you can, because I asked him if he could join us over here, but he's so busy working for us that we just enjoy his presence from there. Thank you so much for what you're doing. Now we get started with the scientific parts. So I think we can go with Pauline.
Hello, everyone. I'm Pauline Raymond Martinbeau, and I would like to thank you for allowing me to discuss today met and unmet needs in aesthetic sclerotherapy. I have nothing to disclose. Leg small veins are very common in the general population. They are considered a common cosmetic concern. And sclerotherapy is the gold standard for treatment of reticular vein and telangiectasia. It is safe and effective, of course, if it is used correctly. One of the problems that we see very often is that the source of the small veins is not always well pinpointed, and the techniques and protocols vary according to treating physicians. Reticular venulectasia, telangiectasia are complex vein, and that's what makes the problem. It is very important to really do a thorough examination to find the source of the clustered telangiectasia. Cosmetic outcome will depend on the treatment of this underlying condition and not on visible clustered telangiectasia. We are lucky. We do have great assessment tools, and now we have duplex probes of 18 to 20 megahertz of frequency that allow us to gain better insight into small veins and then help us to assess the underlying reflux points and degree of reflux. A double-blind study was conducted involving 884 small vein clusters. And in this study, we found that telangiectasia source was 8.1% in the perforators and 18.8% in the saphenous veins. And when you have a clustered telangiectasia like this, which is very, very bluish, and the telangiectasia are very, very, very fine, like little threads. You have to find the perforator that is located at the apex of this clustered telangiectasia. Otherwise, you will not be successful treating this. If you have telangiectasia like this here, you do have to find also the source, and the source will often be in the great saphenous vein. And if the great saphenous vein is left untreated, you will again not be successful treating the clustered telangiectasia. And when the deeper source is treated first, the small veins may just disappear. And they may disappear with light treatment, or they may disappear even without treatment. The C1 small vein management is done by treating the reticular vein here that is connecting with the apex of the clustered telangiectasia. It is feeding the telangiectasia, and if it's not treated, again, the telangiectasia will not disappear. In order to manage this case, one needs to inject the efferent and efferent and not treat the telangiectasia. Avoid treating them. They will disappear by themselves after you treat the reticular veins. There are different protocols for C1. You can use liquid, macrofoam, and microfoam. Macrofoam is a new emerging technique using a wind infusion set with a tubing, and this allows you to get spherical, individual, uniform bubbles. Here's an example of a macrofoam injected in a refluxing clustered telangiectasia, and after eradicating the reflux, you see that the clusters become red and it will probably disappear by itself. We came up with the acronym Manhattan for the complication that can occur after treating small veins. You can encounter some matting, allergy, necrosis, hyperpigmentation, arterial injury, thromboembolism. There could be some technique-related complications, air embolism if you use microfoam, and nerve injury. There is a lack of satisfactory clinical training, and this results in bad outcomes like the one we're seeing here. All these complications could have been avoided. If the treatment fails, reassess the patient, look for the highest or deepest point of reflux, increase the concentration but not the volume, and always keep the volume small. What is the sclerotherapy paradigm? Keep the volume small, use the right concentration for the kind of vein you're injecting, use a good technique, good material, select your patient appropriately, make sure that your patient do have realistic expectations, and remove the coagulum 3 weeks after your injection, and all this will give you safe and effective outcome. There are met and unmet needs in aesthetic sclerotherapy. What's important is that before inventing new techniques or investing in new products, one needs to understand the aesthetic principles of sclerotherapy of small veins and have a majority of satisfied patients. In conclusion, sclerotherapy safety is met and it has been well proven since the 19th century. Efficacy requires a conceptual understanding about the process being treated. Strategic approach is mandatory for aesthetic outcome. Technique and knowledge are the key to success. Minimum effective volume is the main element for safety, and training is essential. More randomized control trials are needed for unmet standardization and to gain evidence-based recommendations. Think about if the patient has met or unmet needs, and first, do no harm. Thank you very much for your attention.
Does it work? Yes. So she definitely deserves an applause, Pauline, as always. And now, as you can see from this special slide, we have, I think for the first time, to celebrate the 10-year representation at the same time from all continents, starting from Africa.
Dr. Wasila Taha, I met her again in Dubai. It was very nice. Wait. Go back.
So we should try to connect her online. If not, we have the recording. I think it's a new thing of the post-pandemic, always having some
Estão na
palpitation.
clínica, estão mostrando na clínica aí.
Can you hear me, please?
Yeah. Well,
Can you hear us, Wasila?
Yes, absolutely, perfectly well. Yes, Sergio.
That is fantastic. Let's see if we can also see you.
yeah.
Oh, here you are. Fantastic, from Egypt.
Hello. Hi. Hello, everyone.
Hello.
And
Hello.
yes, Professor Bayaki, it was so nice meeting you in Dubai, of course. It has been a passion rather than commitment to meet you all, of course. And thank you for the kind invitation, Professor Mayaki, as well as Professor Sergio Giannisini, of course. Thank you for such a great honor to be among you today, and in a very special, unique IMAP event, joining with the VWIN board, now family, of course. About the presentation of Queen Pauline, she delivered a very insightful presentation, of course, for the met and unmet needs for the sclerotherapy in aesthetic approach. And truly, she did touch the subject to the bottom, I mean. My question for Pauline, I guess she is not in person, but she had the recording. And also I could, if you allow me, extend my question to Professor Mayaki. As the vast majority came for the aesthetic purpose are women, and it's not easy, of course, to content women, obviously. She is not, the presence here, which maybe it's with the social media, the fake news, and the TV programs, our patients, they do have really high expectations for their results. So my question is, maybe still in some countries, the unmet needs is the photo documentation. And what sort of photo documentation we should have, and of course, before it's loud and clear, but after, when exactly after? We do sequential photo documentations, or once we have a certain satisfactory outcome. I know Professor Mayaki has his tripod with Nikon with 17 centimeter lens. He has no problem with photo documentation. I'm quite sure of this. And thank you for the huge opportunity, of course.
Yeah, very important question, Vasila. We, as you know, CAP is the most important classification in vein, and the CAP classification is based on ectoscopy. We need to see the patient to classify. And why? Not all 100%, I mean, phlebologists take pictures prior to touching the patient, prior to starting any treatment. And we perform in the average of 40 to 50 pictures before starting. And it's not easy to do that because it takes time, and time is money. And then who pays for that? You? No, the patients need to pay. Then you need to increase your price. And also, to commit to the result is difficult in phlebology, because if you just use one technique that is like, as I say, painting a wall, just go there injecting without seeing what is underneath, and you don't have the experience of taking photographs for more than 20 years, you may be on a trap, because you're going to take a picture and the patient will come back worse, and you need to be prepared for that. And to be prepared for that, what is the, of course, other than education, other than examination, other than the best tools, is charge. Because if you don't charge, if you're afraid to charge, you cannot call the patient to, you cannot, if the patient is complaining about lack of result, you cannot say, okay, don't worry, come here. I will spend 1 hour with the patient re-examining everything for free. And that commitment you only get when you master the treatment, and and most importantly, when you master that you have the value, and you cannot decrease your price to make a competition with your other colleague. You need to increase your price so that the patient, if they complain, they will come, please come in and I will solve your problem.
And that's a very authoritative perspective from Latin America. Now we will have another one from North America, and it will be the one of Professor Martin Bo.
Thank you.
Thank you, Wasila, for bringing a complicated question. Photographs are part of medical record. Therefore, you need to have a consent form signed every time you take photos and state the purpose of the photos. Now, we are not professional photographers, and this can work at times against us. It's important to take photos if you have a complication in order to follow the progress of the healing of that complication. Taking photos to show the good outcomes, it's important, but it's not always mandatory to do that. But what's important is to discuss in your medical record the progress of your treatment. Archiving pictures from the ultrasound is, in my opinion, better than a paper photos or electronic photos. I think that this could be an interesting topic that we could discuss in a group of experts and get the guidelines to take excellent photos and to decide when it's appropriate to keep patients' photos in our chart. Thank you, Wasila, for this question.
We thank again Wasila also for being with us live. Of course, it's a business day, so it's difficult for all the colleagues to be present live. And we fly now all the way to Asia for the representative from Maidol University, Professor Nuttaut. Questions to Professor Martin Bo. Of course, we have to be a little bit patient, not just doctors in these cases, because here we are.
Good afternoon. I'm Nuttaut from Thailand. Thank you for excellent talk. I have one question to ask you. In the patient with corona phlebistatica or C4C who have the blue telangiectasia and red telangiectasia around the ankle, should we perform the sclerotherapy in the blue telangiectasia after working up and treating cause of the chronic venous insufficiency? Thank you very much.
And now, of course, we have to have the reply by Professor Pauline Martin Bo. Do you have any comment on the management of corona phlebistatica meanwhile?
Well, you mean on the side of the...
Corona phlebistatica.
Oh, okay. Oh, normally you have perforant veins and you have reflux on the saphenous vein, and you may have a patient that is asymptomatic, but you have a reflux on the saphenous vein, and she's asymptomatic, but she has a reflux. That means she has a disease, but her quality of life, in many cases in my patients, is compensating her leg. But if she break her ankle, or if she fly to Istanbul in a coach class, they might have a problem. And it is disease. That's why sometimes we need to treat the vein that is asymptomatic to achieve the result. And many times on that place, you need to remove the feeder vein as well.
Do we have the answer, Pauline, ready there? If not, I will make a comment on the importance of the weight-bearing analysis on these patients, because I have a question mark with these patients who clearly have an hypertension at the ankle level. We never focus that much on how they walk. Looks like a minor thing, but in reality there is a nice publication by Hull who is showing that in reality you have 4 times the risk of developing venous hypertension because of wrong weight bearing. So do you think in a modern Flebo suite we should be also capable of detecting weight bearing issues and collaborate better with the physiotherapy ward, for example?
For sure. In all patients, as we are private, we perform the ultrasound in 100% of the patients. That's why we detect those type of diagnoses, because many countries it is forbidden to do ultrasound to perform ultrasound in a C1 patient. But we also do the photoplethysmography evaluation in all patients because it's private, and I want to see the movement of the calf and the ankle and everything, and we always see the weight, the height, during the consultation as well, what they do, what time they wake up, when they sleep, how they have their life, so that we can treat not only the veins but the whole patient, improving literally the quality of life.
That's good. So I'm looking from the director if you're ready to go. So we move forward.
Dear Dr. Nutevit, thank you for your interesting question. Coronophlebectatica is a sign of advanced and severe venous chronic disease, often associated with leg perforator or great saphenous vein incompetence. Treating the origin of the reflux should reduce the hyperpressure in the blue telangiectasia in the coronophlebectatica. The blue telangiectasia may turn red after the eradication of the most proximal reflux. If not, the blue telangiectasia, and especially the venous pearls, this is the round blue telangiectasia, should be treated by sclerotherapy with a low concentration of polidocanol or STS liquid, 0.15 to 0.2%, or with an osmotic sclerosant, and using a very small volume, almost only drops. This treatment will prevent an episode of hemorrhage. We need to remember also that at the foot level, below the malleolus, there is no valve, and the blood circulates in the opposite way. So caution is the key of success. I hope that this answers your question. Thank you for this interesting question.
We thank again Professor Nutevit for joining us from Thailand, and we move forward to Europe.
Dr. Matthew Josny is the president of the French Society.
Thank you very much for this very didactic and educational presentation, which is very of the utmost importance given the number of patients treated each year throughout the world as this condition affects so many individuals. It is indeed important to recall the basis as you have done so well. It is also imperative to remember that this is a medical act above all, and that serious side effects are never far away if the rules are not respected. It should also be remembered that the expected effect in the treatment of spider veins and telangiectasia remains an aesthetic results, and that a side effect that would not have a positive results is not satisfactory either for the patient or for the doctor. The rules must therefore be respected at all levels. My question concerns the form of the sclerosing agents that you use. I was interested in your presentation in the possible use of macrofoam, which I did not know about. Do you use it? Even in France, we have, even if it remains a practice that does not fall under marketing authorization, some practitioners use microfoam, for example, polidocanol, with a concentration of 0.125% for the treatment of spider vein with correct results. However, as you say, we lack studies. The last Cochrane review remains there also inconclusive on the results. Concerning your practice, do you use this form? I thank you again for this very nice presentation.
For such a question, I think we really need Queen Pauline Martin-Beau for the answer. That look like Lorena Grillo more than Pauline Martin-Beau. She's very experienced. I don't know if Lorena wants to try to answer to such a difficult question, but I would go with Pauline if you have the video. Lorena, can you hear us? If not?
Yes, I can hear.
Would you like
I can't be heard.
Would you like to dive into the difficult topic of microfoam versus macrofoam, particularly because this is the temple of the anti-foam, because Kazoo told us indeed that we cannot talk about foam sclerotherapy.
You can talk, of course. I don't use, but you can talk.
Sure, but the topic was at the beginning also of today, lessons that in reality we can avoid to do that. And where do we stay, in your opinion, in this moment worldwide? Because still there is the concept also in the guidelines of using foam sclerotherapy. Do you see any advantage nowadays with the new techniques and the new devices that we have? Or do you still think that we should just stay out of the foam field?
I believe foam therapy are very good because of the cost of it. But if you don't think about aesthetics, but if you want to take pictures and commit to result, and if you are talking about the feet below the ankle, you need to think about surgical procedure. You need to ligate. We have really tons of photographs before and after showing excellent result and long-lasting result, more important than that. Closing the refluxing veins and performing clacks on the top of the small veins. And that's our experience, but I cannot answer about foam versus microfoam. I cannot say.
If I can make a comment on this, I think one thing is the empirical experience we might have, for which it's fundamental attending meetings where we learn from the experts. Another thing is the evidence-based. Now, we are talking about a session that is trying to bring clacks from the huge experts' hands to a standardized and reproducible methods. And in this sense, maybe clacks is easier to be assessed, scientifically speaking, because you describe the method that can be reproduced. The problem with this micro and macro foam and the different bubbles, I will mention also during my talk. Does it really make a difference, clinically speaking, or is like the hands of the ones doing
It's difficult to design the study. There's a lot of bias inside. The cost of the study is not easy. Who would pay for this study? And like plastic surgery, it is a kind of art that we do. And a lot of development is made by try and error for each doctor. And to be able to show your experience, you need to take a picture to say, okay, you see this feet, see how it is now, then you can show. But only with the statistics is difficult without picture. And how do you measure the result using the picture? There are ways, but it's not easy.
It really reminds me of a quote of Picasso, talking about aesthetics and art, was saying that before changing the rules like an artist, you should learn the rules like a pro. So the importance of going to the proper training centers for foam or for clacks, so to be able to assess it at best. I think we can move forward, Bono, if we have issues and we have Lorena with us. So Lorena Grillo, it's my huge honor to present her. She is a key opinion leader from Central America. The very last good meeting before the pandemic was Flebo Latam in Costa Rica. Next one will happen very soon, and I'm sure there will be collaborations between Brazil and Central America as well. So Lorena, are you with us still? She got scared by the question of microphone, very probably.
I'm here.
Oh, you are. Perfect. Nice to see you. You're in Brazil now.
Nice to see you. Yeah, great. Congratulations for this great joint meeting, and thank you for the invitation.
So would you like to make your comment or question to Professor Martin-Beau?
Yes, well, first, to congratulate Dr. Martin-Beau for this great presentation. We had a very concise and full of information presentation. And also, when she mentioned the complications Manhattan Guide, I think it will be so important to use this, maybe to have a standardized informed consent for patients that are going to be undergoing
Thank you very
aesthetic
much,
sclerotherapy.
Do you have the reply ready from Canada? So introducing the topic of the informed consent, I think it's always important to stress out how complications can happen, particularly if you're doing foam. In Europe, we have guidelines reporting up to 30% of hyperpigmentation. So I always suggest during the courses to make it loud and clear. Now, I kind of disagree when they are saying that this hyperpigmentation, if you really read in the documents of the different guidelines, that they are like spontaneously disappearing in a year or so. Unfortunately, not in my office. So same thing for matting. If you really read, you see that it's saying that in 3 to 6 months, matting can disappear. Not in my office, unfortunately. So I think we should be extremely honest and point this out. And I think that is interesting is also how we can eventually reduce this issue with, for example, we have topicals in Italy for the iron uptake, but maybe these are not of interest in a scenario like CLACS. So later on during the discussion, maybe we can talk about what is around CLACS in the peri-procedural stage, any topical that can happen, that can help.
Well, I'm going to discuss about the CLACS. What happens with CLACS in these topics of hyperpigmentation is really low, and matting also is something in between 1 to 2% only, because it's a very focal treatment, and you have you don't have the necessity of asking the patient to come back to drain the clot. We don't have clot, almost don't have clot if you perform the correct selection, and it may happen matting. I have patients that have some type of matting that the best way is to wait for a long time and see if they would, because sometimes they disappear or they get better. And then, but most of the times to treat the matting, you need to treat like a complex telangiectasia, treating the feeder vein, because it's a result probably of unwanted lesion of a normal valve. When you inject like foam or liquid, it reaches a normal vein, damages the valve, you have reflux, and then you have all this congestion.
That's good. So can we move forward, or do we have technical issues? Do we have Professor Martimbo answer? Okay.
Thank you very much, Lorena, for this great suggestion. And I also think that we should have a standardized consent form. And I would be very honored indeed if my Manhattan guide is used for that purpose. My comments regarding the consent form is that it should include the patient's diagnosis, the nature, purpose, risks, and benefits of sclerotherapy, alternative treatments, its risks and benefits of not receiving or undergoing a treatment or a procedure, indicating included but not limited to before the list of adverse events begins is recommended, and list all Manhattan possible risks and add the percentage of their occurrence, and add that the bad outcomes could be temporary or permanent. Mention that injection could be performed away from visible veins, state if any off-label sclerosant may be used, get permission to take photos, and make sure that the patients do have enough time to ask questions. And again, thank you very much, Lorena, for your talk. And I think we should create a group of experts in order to obtain a consensus on a standardized consent form. Thank you.
What I like about the standardized consent form is that you tell the patient, okay, you have to sign this informed consent. Is a standard from phlebology worldwide guidelines, you know. Then because many times the patients are scared about the consent. But if you say that not, and I'm not the only one that, and I don't want you to sign the whole scientific society wants you to sign this consent and to understand.
This is absolutely pivotal, I think, in this phase. It's also interesting to understand what we can really commit to, particularly in terms of recurrences, I think, because then they ask and then they complain, and you really teach us how to really produce all the material about that.
Tomorrow morning, there's going to be the vein club from Albernas group, the vein club, at 7 a.m. We're going to have a discussion, and I'm going to show a very challenging case that I've treated with CLACS and a 10-year follow-up. It's 255 photographs that I summed up to 160 only, okay, but in a mosaic form. And so that you can understand that, and this patient was like, he's cured, she's cured. It is not zero recurrence, and her legs 10 years later looks younger, and there's no recurrence at all. And it's a very challenging case. And I believe we are still always learning how to treat and to be more able to predict the result.
And indeed, with this part, we finish the first round of all the continents, and we go back to Brazil. It's a pleasure to introduce another giant in the field, not just because he's tall, but because he's really well prepared. And it's Fabricio Santiago, of course. He's playing in his house over here, so he will tell us about MET and unmet needs in aesthetic lasers.
Okay, now it's working. After having a presentation about the gold standard in treating reticular veins and telangiectasias, it's very hard to talk about a technique that is still looking for its standard. So I'm here invited gently by Professor Miyake and Professor Sergio Nardini to talk to you about met and unmet needs in aesthetic laser. The kazoo. The pointer, do you have it, please? So for you to have an idea, Dr. Pauline Martimbault, that lady that you saw here, described the association of telangiectasias with the superficial and deep venous system in 1995. She's one of the first ones that have published this connection for you to know the importance of this session. So for not being misinterpreted, I have no disclosures for this presentation. And everything started back in the 60s when Dr. Charles Towns has shown that laser was possible. And only in 1981 that Anderson Parrish has described the selective photothermolysis theory. That is the theory that allows us today to know the interactions between the transcutaneous laser and the living tissue. So this is one of the first MET needs. We need to understand this interaction so that we can understand that we have, after touching the light, touching the skin and crossing the skin, that we have the absorption. That is the main goal that we need. We have scattering. That is a problem that we have. And we have refraction. Understanding that, we allow us to know the wavelength that we need to use, the pulse duration, the fluids that you need to apply to collapse the vessel, and so that we can cause irreversible damage to the target. We have some indications already accepted nowadays: needle phobia, sclerosant allergy, sclerotherapy failure, and one of the indications that I not totally agree with, small veins with telangiectatic matting. And in terms of efficacy, this is a very nice publication by a Brazilian group here from São Paulo, from Escola Paulista de Medicina, where they have shown us that comparing transcutaneous laser with other techniques to treat reticular veins and telangiectasias, there are no differences in terms of efficacy. Is as good as the other techniques. So we have a criteria today showing that laser, it is possible and it works. And in terms of literature review and the reviews and the indications according to some guidelines, we have a very strong recommendation grading, of course, with different scientific backgrounds for that, for different types of lesions, showing us that the laser, that the laser works. And once you understand all of those needs and all of those criteria, we can see that disagreeing with Kazoo that told us this morning that we don't need to understand the interactions, I think that we need to. You can see that when we're thinking about monotherapy, this is very important. The slide is showing that when we choose the appropriate spot size with the right fluencies, we have the total disappearance from the telangiectasias. We have to do nothing more. And of course, for reticular veins, and one of the main problems is pain, because we all know that transcutaneous laser is painful. But once the patient is accepted and it tolerates the pain, we can have some very nice results with monotherapy. This is not something that usually occurs. And one of the main things that I personally think that we need to have transcutaneous lasers in our office. So the dermatologists, they very often address patients for me for treating facial telangiectasias, for treating facial veins, for treating cherry angiomas all over the body. They don't like to treat it. They don't want to treat it, especially in the face. And this is an example of venous lakes that sometimes occur in the lips with very, very nice results. In terms of safety criteria, we already have it. We know that we need to cool the skin so that we can minimize the pain, and for us to protect the skin against the thermal effects. And this is a problem. Now we're going to the unmet needs. One of them is something that has been already said. It is the difficulty that we have once we're working with the system that has a high pressure, that is the venous system of the lower limbs. It has a complexity. Telangiectasias are connected to superficial venous system that is connected to the deep venous system, and often we have problems from reflux in the deep and the superficial venous system. And so we have refractory telangiectasias, patients that we don't have results, so we need to scan properly these patients, and probably this is one of the most problems that we have once we're talking about monotherapy using transcutaneous lasers. So this is what we have arising, the association of techniques, and here we have the CLACS as a star. We know that works really well in most of the cases of C1 patients, but we have other association of techniques to minimize the problem of the association of the reflux, patients with reflux. We have association of foam with transcutaneous laser. We have association of different wavelengths. Sergio Jaresina has published a paper where they have associated both two different wavelengths for treating telangiectasias with very good results. And as Kazoo said this morning, and I totally agree with him, we're outdated. So when we talk about pulse duration, we're talking about thermal relaxation time, and this is a now totally outdated concept. We have to work with the Arrhenius thermal damage equation. We're talking about total penetration time. We're talking about a vessel that have a flux, and we're thinking only about the static thing. It doesn't work like that. It's something that we need to study more. In terms of efficacy, now I'm repeating the slide that I have mentioned, because we know that transcutaneous laser works as well as the other methods, but is it worthy in terms of cost efficacy? We don't know that. We don't have studies for that. We need to know the return of our investment. I know Kazoo is going to tell me, oh, I'm talking about private clinic. I don't have problems charging the patients, okay. But we need to understand that we are working with a tiny part of the population. We need to think about the other part of the population. And as staff in residency and a professor in university, I can tell you that even the poorest patient, especially the women, they are worried about static. So we need to know, because we need to know, do we have to have lasers in our universities for treating hemangiomas, for treating venous lakes? These patients, they also need to be treated. In terms of recommendation gradings, this is a problem. This is a very recent published guideline for European Society for Vascular Surgery, where we can see that we have disparities in terms of recommendation gradings. We have one telling us that we have strong recommendation, other not, and we have different scientific backgrounds according to different guidelines. So we need to solve that. problem, I don't know this, probably I don't know if this is the solution, but appropriate randomized controlled trials, as has been mentioned, is very hard, very difficult to do because an expensive treatment. But only by doing that, we could have homogeneous evidence and solving the problem of having heterogeneous parameters that we usually found in literature. So I strongly invite you to know VWin Foundation, Dr. Sergio Gianesini, Dr. Willie Chi, Dr. Oscar Bertini. They saved a lot of minds during the pandemic. Go to the website, see the work that they have been doing in terms of continuous education, in terms of networking. It's outstanding, and please be part of the VWin family. Thank you very much.
Can I have okay. Thank you so much for this finale, which will not save you from tough questions from all around the world. Starting from Africa, we should have with us another giant figure, which is Professor Ayman Fakhri, and if he's not connected, we have the video. While we are waiting for the video, Fabricio, I will get back to the point of the guidelines. Oh, here he is.
Good morning, dear friends. I'm Ayman Fakhri from Egypt. I'd like to thank Professor Sergio Gianesini for inviting me to this great event, and I think it is my first time to be here in IMAPX. I'd like to congratulate Professor Fabricio Santiago for this marvelous presentation and achieving and get these very good results with laser therapy for dealing of telangiectasia. But my question, in such cases with telangiectasia fed by reticular veins, how did you achieve this good result using monotherapy laser and abolishing these reticular veins? Do you think that this will be sufficient for such cases, or you may need other added therapy as injection sclerotherapy? Thank you, and see you soon.
So, okay, I'm probably talking about my personal numbers. 95% of the cases I use in C1 patients, association of techniques, the CLACS technique, and in some cases I have very good results with monotherapy, and the main problem is the pain, and one of the main problems is the association of telangiectasias with the superficial venous system insufficiency or the venous system.
I totally agree, but I use 100% of the cases I use CLACS, and I only use monotherapy, which would be like transdermal laser and cold air on the facial veins. Well, now we call Ravul Jindal from India. He was probably going to be here, but we all were affected by COVID and war and everything, but I'm happy to see you here, Ravul. We were together in Dubai, having a great time there.
Is he live? Hi, Ravul.
Yes. Hi. Congratulations, Professor Kazu and Professor Sergio, for a joint session. And thank you for the invitation to be part of it. And thank you, Kazu, for the invitation. And, it's very difficult to travel, but I'm sure next year we will be with you. And, Professor Fabricio, it's a fantastic talk. And, from last 4 to 5 years, we have been trying to get around one question. And, this question, Professor Sergio, is to you also. As an association like UIP, you are part of the UIP, as a VWin, and all the big stars are there in the phlebology group. Why can't we design a simple study? Maybe to answer 1 or 2 questions, because I came to learn CLACS from Professor Kazu like 4 years back, and in 2022, we are still fighting the same thing, that we don't have the literature. So my concern is that in 2025 or 26, we should not be standing here and discussing the same thing. that we don't have the literature. I think there are a few simple studies which we can do and at least answer one or two questions. Because my major problem in the clinics is that some people are able to afford clerks and some are not. And the results with the clerks are very consistent. So that you see in your clinical practice. But when you do a microfoam, with a dilute sclerosants, the results vary because sometimes you get very good results and sometimes you don't. And so we need to at least, reach at some conclusions and some guidelines, if we have such type of telangiectasias, what should be the best approach or maybe the second best approach.
Was that a question? Revul, you asked me, if I can see any differences when seeing the telangiectasias in terms of what I need to do, right?
Yes, that is one question, but my basic question was why we are not able to move forward in terms of, we are so many associations are together, why we are not able to design a simple study and take at least answer one question.
So Fabricio is doing that just because he wants me to go first so that he can copy my answer very probably. Jokes aside, because we are among friends, I totally agree with you. We keep on hitting our wall with the head along the years. And I think the problem is always a standardization and reproducibility, as I was saying before. So we should agree to move forward one step at a time. Because if I have to compare two populations, you were correctly saying when you see clerks, for example, it's kind of standardized, so it's pretty easy to see the consistent result of that. But when you turn to microfoam or different techniques of injection, that's where we should really agree how we want to design the study, because we know that, for example, the blood proteins are inactivating the sclerosant. So even the number of pokes we do on the same tract of vein, for example, if I have 10 centimeters of veins, let's say so, and I just inject once, it will be extremely different from injecting twice. When we look at Facebook and we see these amazing videos of the spider's veins disappearing with just one injection, we understand we are getting into the field of fake news. And I totally agree with you, and it's our responsibility, and we should really start doing that, starting with a simple study that have to take into consideration, though, all the many variables. So I would revert to you the question, or to Fabricio, which would be the first variable to take into consideration, because even the Fitzpatrick type would be a variable, the number of pokes would be a variable, the kind of lifestyle would be a variable, the age, of course, the kind of cellulitis you might have, if you want to consider about that. So my suggestion is to go in a study that, and this is my fault with Marcelo, because we have been talking about this for 3 years now, same patients, 2 legs with 2 different treatments, which also includes the issue of how to do an informed consent of a study like this. Who is going to give us their legs to experiment on one side and on the other side? So I totally agree with you, we should do that. I think we should agree on what is the most important thing. In my opinion, the most important thing is to get started with standardization of sclerotherapy. If not, we get the risk of having also commercial telling us that we need to use a specific foam to have a better result, when in reality we don't have real outcomes for that.
Yes, Revul, I think Sergio have already answered one of your comments or questions, and the other one, I have 2 tips that I continuously tell to my residents and to the students. We're used to look at the SIP classification, so clinically speaking, telangiectasias, reticular vein, no. You need to touch the patient. Test the refilling time of the telangiectasias, the direction of the refilling, where does it come from, and you need to appropriately use the ultrasound. We're talking about high frequency ultrasounds nowadays that we can see the skin itself. We can see the telangiectasias. So there are no excuses for not seeing what is underlying that telangiectasias unless they are essential telangiectasias that are those tiny ones, the red ones that has nothing to do with anything. This is another problem, another discussion. But I think in terms of telangiectasias, touch the patient, examine your patient, look for perforating veins using your touch or using the ultrasound. I remember Kazu telling that Professor Hiroshi had an ultrasound finger because he examined all his patients and he detected the perforating veins. And so here's the problem. He didn't need the ultrasound. But nowadays we have, so we can use both tools for that.
Yes, for sure. With the ultra finger, you can do a lot, but of course, with like a 12 megahertz like mine from 2015, by that time was the best produced, is still very sensitive and enough for what we need to find the feeder veins. And by as I don't do foam, never in my life injected detergents, and then but I'm also ready to help you and join in any paper and design a study to try to analyze and compare CLACS to other techniques so that we can have more conclusions. But aside of science, we need to understand that if you already bought your Flebo suite, you are losing money when the patient comes in and say, okay, no, it's too expensive. Can you do just the injection? No. At this patient, you need to say, okay, I have a lot of experience in this technique, and I don't perform the other technique. Because if you lose time with that patient, this patient will bring her friends that don't have money to pay for the CLACS technique. And then you need to focus. It's like you have the best restaurant, Michelin restaurant, and the guy say, in Italy, you are in Italy serving the best Italian food, you have many stars, like 3 stars Michelin, say, can you prepare a hamburger for me? And you say, okay, you don't have money to pay, and then you lose time, you lose focus, and this is not talking about science, I'm talking about business. But of course, we are here to discuss how to have conclusions, and we need those conclusions. But even though if the conclusion is that CLACS have the same result of sclerotherapy, I would keep on CLACSing the patients because I have 0 anaphylaxis, and that's only solo for that, saving 1 patient in my whole life would be enough.
My feeling that paradoxically CLACS could be even easier than sclerotherapy to get to the same level, because
I agree.
Easier, like the way we published a paper that I encourage you to read on JVS and Journal of Vascular Surgery, where we really tried with Kazoo to standardize the technique and make it easy to be understood. And that's far easier, I would say, than becoming a very good sclerotherapist. But of course, modern phlebologists should have both. Sure. So thank you so much, Raul, for joining us. Now we fly all the way to Europe. It's a huge honor for me to introduce you Professor Rodrigo Rial. He's really a key opinion leader and is really the bridge to Europe, I'd say, from Latin America. I hope he's with us live so that he can also tell us the name of the city where you will have the meeting. That is just the first city you meet when you cross the Atlantic, isn't it?
Boa tarde a todos. Good afternoon, good evening from Europe, from Spain. I'm really honored to be here with all of you, and thank you very much for the invitation. Congratulations, Fabricio. It's a very, very, very nice presentation. And used to do the laser enthusiastically many years ago with the first devices. And to be honest, then I was a little bit disappointed compared to the expectation created. I believe that this is a useful method, but second line with respect to sclerotherapy. I think it continues to be used because so much specialization is not needed, and even medical personnel are not necessary for its application. Well, it's not necessary. Some not medical personnel apply the laser, as you know. And isolated spiders, I think, works decently, but the cases with reticular varicose veins, also named as thread veins, are where we have less good results. And it is true that with the new devices, fewer sessions are needed, and also they have fewer complications, and the for is less. And finally, the question is, what's the percentage of the patients who come to the office to be treated with for aesthetic varicose veins? You treat with only with laser, and how many with combined treatments or only sclerotherapy? Thank you very much. Thank you very much again.
I think he asked, Rodrigo, how are you? Fabricio here. So you're asking me how do I choose the appropriate treatment for the different types of... So I objectively telling you, see one patient, CLACS, with refractory telangiectasias, phlebectomies, or sometimes foam. And above that, phlebectomies and with C2 patients above, probably endovenous laser therapy associated with phlebectomies.
Sorry. In my opinion, I almost only use sclerotherapy for telangiectasia for spider veins and also reticular veins. So my experience with laser is very limited with the new devices.
Have you ever tried CLACS, Rodrigo?
Sorry?
Have you ever tried CLACS?
No.
So then you have to come next year.
Yeah.
You're invited.
Sure.
Feel invited. Yeah.
Sure. Yes. I'm waiting for the invitation.
What is the name of the town of your meeting? Like the next one, like the first one landing from the Atlantic.
Sorry?
The name of the town where you're going to do the meeting. That is the first one landing in Europe.
Yeah, Vigo. Vigo in the northwest, of Spain. The next meeting in Spain.
So there will be a CLACS delegation.
Yes, Vigo, in Galicia, northwest of Spain.
Thank you so much, Rodrigo. Now we move forward.
Thank you. Thank you so much.
We move forward for Dr. Serraude from Mexico.
Should be here with us. Technology is beautiful when it works, we learned during the pandemic. Here we are.
Okay.
Hello, everybody.
We can hear you. Shoot the question.
Hello. Thank you very much. Congratulations for this wonderful meeting and really this wonderful presentation about it. Very interesting when we decide to treat the patients with telangiectasias or reticular veins. So I want to know, what are the most common complications that you can identify when you decide to treat the patient with laser therapy? Thank you.
So, hi Javier, Fabricio here. I couldn't say complication, but side effect is pain. And in terms of complications, especially in the untrained hands, if you're not using conservative parameters, just like in CLACS, is burning. You can burn your patient. I have one burn since 2010, and it was because of stacking. I performed 2 or 3 shots in the same time in the patient accidentally.
Stacking, right?
Yes, stacking. And
Shooting at the same time.
I had a hole on her leg.
Yeah.
And it resolved in how much time?
Yes, in 3 months.
Okay, so it's
with
manageable.
hypopigmentation at a very small scar, but the scar was there.
Okay. Thank you so much, Javier from Mexico. We look forward for being there with you at the next event.
Thank you very much. Thank you very much. Regards to all of you.
And now it's time, I think, for a standing ovation, because we are moving for the next talk. That is Professor Kazuo Miyake, to whom I like to give a standing ovation because I think he really needs it. So we should just give him an applause for what he's doing. I think he deserves it. Please go.
Thank you, everyone. Well, this is a kind of different presentation because I put a presentation with zero photographs. And I wanted you to focus on what I'm talking. And the conflict of interest, of course, I have several sponsors here. And I will present at the clinic soon a CLACS session sponsored by Iconi Lasers. And what have we met so far? One of the greatest achievements, of course, the greatest achievement is doctors and patients happy with the technique, but the greatest scientific achievement, other than publishing the paper, and maybe that's a result of the published paper with Sergio Zanizini, is that the CLACS is now at the European Guidelines of Phlebology. This is new, it is from December, and it's very important. I've been for many, many years going through conferences, sending papers. Papers will be rejected, or going through the abstract to the poster sessions. And I have a lot of cases about that in the United States, all over the world. But I keep on going. I keep on teaching, and some doctors I would call them and show on the computer, and they went to the clinic to practice and started to perform. And of course, as I said, it's really rare to have anaphylaxis. But how can you explain to the person that it's really rare if his mother died during a CLACS session, sclerotherapy session? It may be 1 in 20,000, 1 in 30,000. And once I asked a famous doctor when STS put alteration on the patient's information that at least 6 patients died due to the use of Sotrodecol. This was like 10 years ago. And I asked this famous doctor in the US, what is your opinion about this? And he said, 6 equals 0, because there are so many people performing sclerotherapy in the world that 6 equals 0. And I was shocked with his answer, because I was hoping for a different answer. But anyway, CLACS is a combination of cold air, transdermal laser, and dextrose. Then it's sugar, light, and cold air. And one technique, as soon as I'm going to show today, it boosts the other. That's a synergy, it's not a combination. And that's why it's so interesting, because we use technology and we are 0 risk of anaphylaxis. And this is really important when you are talking about aesthetics. We also avoid with dextrose. My father's PhD, we are going to, I don't know if it's already there on the website, but I'm putting all the papers, important references about this, and this, my father's PhD as well, showing why dextrose, 75% or 50%, cannot cause skin ulcer after sclerotherapy. And skin ulcer after sclerotherapy is something that is also need to be 0, because a patient comes in, and this happens to the patient that is worried about the tiniest little vein. And why that? Because this tiny little vein has a low outflow, and it's easy to exceed the vein capacity, flow capacity. Then you push the sclerosing agent towards the capillary system, and you cause a necrosis. It's a progressive necrosis, a second healing intention. And you cannot do that. And normally it's a lawyer, busy lawyer, that comes at the end of the day, the doctor is tired, and she's a skin stretcher. Do you know what a skin stretcher? The patient that say that, oh, my legs look horrible, and then, oh, really? Where? And then she shows and stretches skin here. Look, this vein. And that's the most dangerous vein to cause a skin ulcer. Other CLACS have met is treating telangiectasias reticular veins up to 1.5 millimeter. In our case, my father, as he taught me, used dextrose 75% or phlebectomy. That's your tools, when he taught me. And I followed him, and we were performing a lot of phlebectomy in veins that were smaller than 1 millimeter in diameter. And I could avoid 86% of this huge, long, 5-hour, 3 doctors phlebectomy under a spinal block. Now we do everything in our clinic with 2 phlebo suites, sedation only. The patient comes in, treats CLACS, endovenous laser, ligation of peripheral veins, and goes away with compression stockings and 0 need of resting. Now the next day she can drive the car, she can go back to work. We also met other very important, that because CLACS is only dextrose, we can perform a huge session. We don't need to have a limitation of sessions, and nobody wants to go to the phlebologist every week 2 times for 10 times, and worse than that, achieving no expected result. Then the patient comes in to solve the problem, and we treat less patients, but with much more result. other, decrease recurrence. I'm going to tomorrow morning, 7 a.m., we are going to broadcast this for free, this vein club session, and I'm going to show this long follow-up. And we can decrease recurrence because we are very focal. We treat the problem. We remove the network, the group of veins that were refluxing. And all parts of your skin and fat, they have parallel systems of vein drainage. That means that vein system that is dilated is not the only one there. There are many systems. And we are removing that system, but very gentle and precise, because the laser will affect only the vein that we aim, and the dextrose is only with a lot of punctures, very precise. That means we don't affect the other vein systems or normal veins. As I said, there's a treatment option for veins up to 1.5 millimeters. We've been using this treatment since 1999 in our clinic, this method, and it's the only method that I use. I don't have any other tools. And we are here. And we've developed this congress, and we have the clinic which is continuously growing, and it is a type of evidence. Of course, it's not a scientific evidence, but there are doctors for more than 40 countries using CLACS. That is another evidence. It's not a scientific evidence. Once again, we need the scientific evidence, and that's why we are here. Well, but what are the unmet for CLACS? We need to improve now. Lack of proper prospective clinical trial. We are talking about this. And then understanding what is the importance of each part. If you do without cooling, only transdermal laser, as Fabricio was saying, only sclerotherapy, what can the sclerotherapy do? As I don't do detergents, many times when I have, all the time, sorry, when I have a difficult vein that I couldn't remove in the surgery, I treat with dextrose. I inject dextrose guided by ultrasound. And it's an internal joke because always Marcelo and Bono say to me, okay, now is the time we need to use the foam. Say, no, with dextrose, if you do 1, 2, 3 sessions, you close any perforant, any vein. Dextrose 75% is not the strongest one, but it is effective, and it's possible to inject, and even with the guidance of the ultrasound. I've did that for healing ulcers at the house of an old woman as well in the past. There's a repetition. Yeah. Sorry.
With dextrose,
great success.
1, 2, 3 sessions, you close any perforant, any vein.
Well, also we need to understand the return over investment, and Gustavo Marcato today presented about that. It's really good, but we need to know the numbers. We need to understand more, but it's really profitable. And also estimating the improvement of quality of life, because many times the patient have a static problem, but this led to gaining weight, led to not going to social events, not going to the gym. And so many times I treat a patient and I change her life, because they get married after that, they lose weight, they go back to the gym. But we need to have numbers about quality of life, right, Daiane? Well, then, at conclusion, let's do science with CLACS. And give me a call or send me a DM on Instagram, because it's easier today, but you can have my cell phone number as well. And feel free to invite me. I'm 100% focused on the science and to go forward so that we can have more numbers for CLACS. Thank you very much.
Thanks to you, Kazu, also for the honor we had few months ago when we were together in Dubai, because it was a truly honor to see Kazu showcasing CLACS in a dedicated session with a new community of friends and colleagues that is represented now by Professor Dina Al-Qaedra from Dubai Health Authority, one of the highest institutions in the region.
Good morning, good afternoon, good evening. Greetings from Dubai. Thank you very much for giving me the opportunity to be among you during this nice event. I would just like to comment about the safest and the maximum volume of treatment for varicose veins during sclerotherapy.
And now this is a tricky question for you.
I have numbers for that. We perform, we've evaluated in 2016 almost 500 patients, the number of the volume versus the number of shots, laser shots. And the average is 100 shots, we have 1 ml. That means when we treat a patient that we do that, well, first I need to explain that this is an average. 100 shots, 1 ml. That means each shot is 0.01 ml. And also, when you have bigger veins, you use more dextrose. But when you have smaller veins, like telangiectasia, this volume is even lower, much lower. That's why we can perform like 4,000 shots in one patient. And that would mean 40 ml of dextrose 75%, which is not so much for during 3 hours. It's not so much. And the number is less than that. And that's the great part of the class technique, because we don't have the limitation in the session size.
It would be interesting if we have time to discuss about diabetic patients and CLACs later on.
But is it because sometimes the patient asks, oh, I have diabetes. The answer is that if you want to treat your leg aesthetically speaking, and you have diabetes, that means that you're not worried about your kidney, you're not worried about you have a controlled diabetes, probably type 2 or even type 1 with a very good control. But you have a disease. If you are sick, ill about the diabetes, you won't be worried about your telangiectasias. You are worried about your kidney, your life, and your legs and everything.
Good. So now it's a special moment because we go all the way to Japan. We know we are...
Thank you very much for a nice presentation about CLACs, Dr. Miyake. My name is Makoto from Japan. CLACs is
wait a second, because if you can stop it, because I understand the
guideline
technical team
in
can have issues, but
2022 this year.
this is very important to mention, because there is somebody who is a huge professor, Professor Makoto. It's 3 a.m. in Japan, and he's connected with us. So I don't know if he can just say a word if he's here or later on. Later on he will join us, but just to let the audience know that in a place, it has a particular meaning, I think, because CLACs has a heart in Japan, I think also.
Yeah.
So we look forward for more and more collaboration with the Japanese Society of Phlebology, represented by Professor Mo Makoto, a huge figure from Yokohama University. And here is his comment. But he's with us, he's listening.
Yeah, thank you very much for invitation to the great meeting. I learned a lot and work. And
that's the live, I guess. Here he is. Makoto. Nice to see you.
Yes,
3 a.m. Just to showcase the cat behind you. Yeah.
Thank you very much for invitation for the great meeting. And I always respect the great patient work for Dr. Miyake. And I'm very happy to make a comment about the Dr. Miyake work. So please play video.
Thank you so much.
Presentation about CLACs, Dr. Miyake. My name is Makoto from Japan. CLACs is described in ESVC guideline in 2022 this year as a prophylaxis procedure. CLACs is used the vein for up to 1.5 millimeter, and the sclerotherapy is performed by dextrose 75%. Each country has a drug-approved system. For example, we can use only polidocanol for sclerotherapy. What happens to use diluted polidocanol for CLACs, for example, 0.25%? Question 2 is, what happens when the CLACs is performed vein more than 1.5 millimeter? Thank you very much for your nice presentation.
Hello? Okay. First, こんばんは。よろしくお願いします。
お願いします。
The first question, ideally, you would use dextrose 75% or dextrose 50%. In any country, you have dextrose 50%, sometimes in big vials with bottles of 500 ml, and you could use dextrose 50%. Dr. Ashish Dadas is going to present tomorrow, and he is using, since he have trained with me at Clinica Miyake 3 years ago or 4, he has been using dextrose 50% with the same result, and by the way, fantastic results. And aside of that, you can use a low concentration because you don't, as I said about the dextrose 50%, you don't need to have any powerful sclerosing agent. But the problem that I see is that you will lose one of the points of what my sensei, my father, told me, to avoid this rare, ultra rare complication that is anaphylaxis. Sometimes the patient is during the session, she's complaining, oh, I'm not feeling well. If you are performing with Clax, you know that it is anxiety, but if you are performing with any volume of polidocanol or STS, you need to push the red button and get everyone ready for the worst. And that means I don't advise anyone to use any detergent. I advise to use dextrose 50% if you don't have dextrose 75%. The second question is what happens when you use Clax in veins bigger than 1.5 millimeters. I've treated in 3 years ago at IMAP one patient that had a 2.2 or 2.5 millimeter vein on the back of the thigh, the distal part, and it was great result. And her legs are treated, and sometimes she comes back to workshops, and her legs are completely, she's a model, and it's completely solved. And why we could achieve that? Because we did a thorough examination with ultrasound, and there was no connection to perforant veins, no connection to saphenous vein or Giacomini veins. It was a bigger, low-pressure vein. Yesterday, during the training, we saw a vein that was smaller than 1.5, but it was refluxing. And we followed the vein, and it was going to a perforant vein. And that means sometimes 1.5, less than 1.5 is not good as well. Well, this is my protocol, but more than one doctors are performing Clax on bigger veins, big veins, 2 to 3 millimeters. And what happens, what are they informing me is not one is a PhD, is not ready, and the other ones they are just telling by us what they saw, is that they achieve less pigmentation than foam sclerotherapy. But there is pigmentation, but the pigmentation is less than the foam sclerotherapy because of the laser. The laser interaction will make the vein wall to have edema, lesion of the elastic fiber, and contraction, and the internal diameter of the vein will be smaller. That's a natural reaction for the cooking with the several passes of the laser, damaging the vein wall, and that causing the situation where you have less clot, and less clot is less pigmentation.
Thank you so much, Kazu, and thank you once again so much, Professor Mo, for being with us, and we look forward for the next collaboration chance. Now we fly all the way to Europe.
Otsukare-sama deshita. Sayonara.
Arigato.
I can just say arigato, unfortunately.
Arigato.
And so we move all the way to Europe. It's still 8:30 p.m., so we owe a big thank you also to Professor Tobias Hirsch from the German Society of Phlebology for being with us during dinner time. He should be with us live. Ciao, Tobias. Can you hear us, Tobias? We can see you. You may be sending him a text that is live. He's actually a very good guitar player, so next time we will have him with Giulio Ferreira playing a piano.
Nice idea.
So is he with us? Can you? If not, we move forward meanwhile to North America with Chris Pittman, if you have issues.
Yeah. Hello.
Can you hear us, Tobias? Either he doesn't know what question to make to you, or he cannot hear us.
Kasu and Sergio, thank you very much for the invitation to comment on CLACS. Kasu, CLACS seems very interesting, very intriguing. I've not performed it. My question for you is, why wouldn't you, after doing this since 1999 or 20 years, do a randomized controlled clinical trial comparing CLACS on one leg and injection sclerotherapy on another leg? I might suggest doing CLACS on one leg of a patient and having a competitor or somebody who is good at injection sclerotherapy doing the opposite leg in the same patient, and comparing the results of that study perhaps in 20 to 30 patients. I think that would be very intriguing and very, very worthwhile. Thank you so much for the invitation to comment.
Hello, Chris. Nice having you. I hope that I can have you here soon, one day. And the answer for that is that I've tried a lot. I've spent a lot of money on simple studies. But like in the beginning, like when I started studying the reaction of the transdermal laser, if I was able to perform photothermolysis in reticular veins, I did one segment, no treatment, control treatment, another segment of the same patient, I treated with the transdermal laser only, and then I did a phlebectomy in both sides and sent to pathologic analysis. I paid all from my pocket. I sent this paper to all journals that I could, and I have in my computer, I have many folders, the submission, and then there was like less try with like a worst medical journal, and no one would accept. And then I kept on studying, and I studied, for instance, the comparison of 18 milliseconds versus 60 milliseconds of transdermal laser, if there is a difference, and I found no difference. And of course, I couldn't publish this anywhere, because in 20 years ago, if you were editor-in-chief for a journal, this guy is crazy. The laser does not work. Yeah, and he's comparing parameters. And after that, and because I've tried also to contact the laser companies to support our studies, but there was no support because they're interested in dermatology. It's very difficult to have 3 laser companies here. We worked for 3 years, every day, not every day, of course, but all the time trying to contact them to be here. And it's not easy, it's expensive, and it's frustrating because I spent a lot of money and I was rejected, and the papers are there. They went to the Brazilian Book of Vascular Surgery. They are there, but they are not in the Medline, PubMed, sorry. And but the future, let's do this forward, and that's why we're here. And I hope that like Fabrizio and Albernaz, Sergio Nizini, Cursat, everyone, we can move forward and study, make clinical trials prospectively.
Well, Winston Churchill was saying that success is moving from one failure to the other without loss of enthusiasm, yeah. And it seems to me that there is enthusiasm. So this was actually Chris Pittman, leading figure from the American Veins and Lymphatic Society, and we thank
you, Dr. Miyake, for this.
And this is Tobias Hirsch going back to us from Germany.
Thank you, Dr. Miyake, for this excellent lecture. I'm Tobias Hirsch, angiologist from Germany. We have learned that we can treat telangiectases and reticular veins up to 1.5 millimeters with a low chance of pigmentation and without the risk of skin ulcer. One problem I'm particularly concerned about is matting. And so my questions are, is CLAX suitable for treating matting? And is there matting when I use it? Thank you so much. My best regards.
Hello. The matting is one thing that the technique of CLAX will, as we perform a focal treatment, we treat only the vein that we see, the vein viewer or the augmented reality device sees. That means we treat the source of reflux, and this will be, it's very precise, and also the injection, as I'm going to show today, is also very low volume and a lot of punctures. Sometimes I do one puncture every ½ millimeter because the puncture itself is a lesion on the vein wall. That means we have a big concern about treating only the vein that is the feeder vein. How do we detect the feeder vein? All the veins that are under the group, the complex telangiectasia, the group telangiectasia, are feeder veins. We treat those veins, and this leads to 1 to 2% of matting. When we see a matting that comes from other colleague or other type of treatment or caused by our phlebectomy, the treatment is the same. We go for the feeder vein, and I can say that more than 90% of the times we achieve a good result. Some patients, of course, rare patients, are resilient, and we need to wait a lot of time to try to see if the matting is, sometimes it's inflammatory, it goes away alone, or we need to perform treatment. But the CLAX is a good treatment for the matting. But sometimes when you see the feeder vein and in a matting situation, regardless what was performed in type of treatment, we sometimes CLAX is not a solution. We need to do a phlebectomy, and I know that you are also a phlebectomy enthusiast, and is right, correct? Yeah.
Oh, no.
No?
No, we do a tributary treatment using sclerotherapy.
Okay, sorry. And then, but anyway, I love a phlebectomy, and then we perform the phlebectomy, which is also a precise treatment, focal treatment. What we need to be focal treated to treat only that vein. When you do sclerotherapy, you need to be aware that sometimes the sclerosing agent will reach normal veins and other veins and you can damage the valve of those normal veins, and this will lead to reflux and worse the situation.
Thank you so much, Kazu. Tobias, any final comment?
Yes, thank you. I know that we are rather late in the meeting, but can I add another question?
Sure. Okay.
If there is a need for both a truncal vein treatment and also reticular and spider vein treatment, do you combine both, or how long do you wait between the treatment of the truncal veins and the tributaries and the treatment, this aesthetic treatment with the spider veins and reticular veins?
Yeah, correct me if I'm wrong. You asked about how do I my strategy, because sometimes the doctor make this staged strategy. Treat the truncal veins in one session, and then if the veins improve or not improve, they do another treatment. In our situation, it's all private clinic, and we try to solve the problem at once. That means we all go to when it's a complicated case, we go to the operating room in our clinic, sedation of 3 hours, and under this propofol sedation and local anesthesia, we treat the reflux with endovenous laser ablation, and we treat the perforant veins, refluxing perforant veins with ligation. We remove the tributaries, and we perform the CLAX all in once. And by the way, we begin, because the laser tip is not sterile, we begin with a huge session in the front and side with clacks, 2 devices each side, 2 lasers, 2 augmented reality and 2 cooling devices. And as we finish the transdermal laser, we perform the surgical part, turn the patient on the belly, and then we finish sometimes a parva, a small saphenous vein, or tributary, or peripheral vein. And then as we finish, then we perform the clacks technique, sometimes from the buttocks to the back of the thigh with the reticular veins, which I call cellulitis veins, and then up to the feet. And this takes 3 hours with 2 or 3 doctors and a whole setting with a lot of devices all around.
Thank you so much, Kazu, and thank you so much, Tobias. I invite everyone to have a look at the German Society of Phlebology.
Thank you for being invited.
Vielen Dank, auf Wiedersehen.
Thank you.
I was saying yes to the German Society of Phlebology, where they have a lot of educational activities. Kazu.
And thank you for being invited. It was very interesting for me.
Thank you so much.
And now I'm fixed on with clacks. I'm going to start with.
Okay. So another one will join next year, very probably in person. Thank you
Vielen
so
Dank.
much.
Vielen Dank, Wiedersehen.
Thank you so much, Tobias. I think it's my time to wrap up a little bit. So sorry if I push the host out of the stage. The idea is to wrap up the session with some concept then on met and unmet needs in aesthetic phlebology, in particular in the peri-procedural context. No conflicts of interest to declare. Of course, I would say that the first thought is always about safety. And it is interesting what we have in the literature that is just coming out now. This is the PASS study from the group of Bradbury that is showcasing in reality how safe sclerotherapy is. But it is true what Kazu always says, you just need one case to really remember the issue you might have experienced, so we must be ready to manage that. As you can see from the larger analysis they did with more than 8,000 patients, we have a story of migraine that can be present as a risk factor for neurological complications, and volume is another topic. But again, we could discuss, I think, since this is met and unmet, about these data, because volume depends also on how you manage the patients when you're injecting that volume. For example, if you are mobilizing that patient very soon or not. You see over there a quote by the Bible in reality. Why do you look at the speck of sawdust in your brother's eye and you pay no attention to the plank of your own eye? Well, in reality, this is to say that when we are talking about thrombosis, in Italy, I think there is a little bit of fake news on the risk of thrombosis in sclerotherapy. Patients are coming to us and saying, oh, well, sclerotherapy doesn't give you thrombosis. No, in reality, it gives you sclerosis. And actually, the percentage of events that you have of DVTs are competitive with the other techniques we have available, but the patients usually don't think about that. You have potentially more risk in doing the other procedures. This is a very nice publication that is showing us indeed the difference between a thrombosis and a sclerosis. Now, if you look at this large population, 007 that you see over there is the percentage of real thrombotic events they detected. The vast majority of cases were actually sclerosis, so thickening of the wall due to the sclerosis. So remember the 007 with a license to kill of a pulmonary embolism just for a very small percentage of cases. But again, we are talking about met and unmet needs today. The idea is to fill in the gap, global aesthetic phlebology, as per the acronym of this session. Now, we live in a new world. We live in the time of COVID, and we know that COVID is an endotheliopathy, which means that we have higher risk of having patients developing thrombosis. It's our responsibility being aware of this, and that's another reason why Professor Caprini is one of my personal heroes. Even in this time, he has been so active and even suggesting the potential need of adding extra scores when we are evaluating our patients. Now, who was in Dubai, remember that we used a t-shirt that was saying, never kill a friend, never treat a stranger. What does it mean? It means that of Fabricio, who is a dear friend of mine, I know all the risk factors because I know what he's doing, his habits. So I don't get the risk of killing him by thromboembolism because I'm not considering that he might have a genetic mutations or some other particular features. So we should always remember this sentence, even when we do just simple spider veins. Never kill a friend, never treat a stranger. If you approach the patients and say, okay, just inject something on those spider veins, you might miss a thrombotic event. Another, I think, met and unmet needs we could discuss is all these commercials about the need of new devices to produce sclerotherapy. Do we really need that? Is it like really going to make a difference? Well, when I'm listening to people saying that currently we don't have standardization in sclerotherapy, I kindly disagree, and I quote Watkins, was already demonstrating how you can standardize and make reproducible a proper Tessari methods. But of course, it has to be proper Tessari methods. It has to be the proper syringe. It has to be the proper way of creating the foam, the proper way of injecting. Then you have, according to the publication, a standardized and reproducible methods. I'm not saying that the new devices are not welcome. They are more than welcome because they help us in standardizing the technique, maybe when we are not still able to do that properly. And potentially they will have better results. But potentially, because at the current moment we cannot stand in front of commercials saying one thing is better than the other until we really compare that. Now, if you look, for example, at the density, at the bubble size, at the half-life of these bubbles, in reality there is a difference, but does it really make a difference, and do we really compare that properly? Because I was not able to find a study really comparing the two different foams productions methods in a homogeneous way. Indications and contraindications in C1. Fabricio Santiago gave us a splendid lecture quoting references, and I'd like to quote this one that was a group effort that we did together with many friends and colleagues after the Winter 2019 meeting. It's available on Phlebology Journal, where you can find the similarities and the controversies of the different guidelines. Isn't it crazy that you have some places, it happened to me with a resident who came and said, like, well, you know, like in the other office they're doing 15 cc of foam, they're going to kill the patient. Well, in reality, maybe they are Australian, I said, because they have just other recommendations, despite the fact that the amount of literature we have is always there. So if you look at the telangiectasia treatment, for example, what we reported in that publication is that there is a different indications in the different countries. So I think this is a time to talk more together for more uniform recommendations. We generally agree on the absolute contraindications of sclerotherapy around the world, while we generally disagree in the different guidelines around the world in terms of the relative complications and contraindications. As I said before, of course, we are all scared in aesthetic phlebology by the residual pigmentation. And as I was saying before, you see over there, it is reported in the literature that you have a spontaneous resolution at 12 months in 99% of cases. I wish it was true. Again, not in my office. Angelina Jolie is trying to wake us up, reminding us that a good compression might help us in the aesthetic results. So we could discuss about the use of compression to improve after CLACS rather than sclerotherapy, rather than laser therapy. But bear in mind that the indication you see over there, for example, from Europe is 2B. So we need, again, more evidence to really say what we need in terms of compression. What about the venous active drugs in terms of aesthetic phlebology and hyperpigmentation? This is a publication coming from Mexico showing us the effect of a drug that is acting on the coagulation balance, reducing the hyperpigmentation after sclerotherapy. This suggests us, in my opinion, that we are talking about thrombosis over here. We are not talking about sclerotherapy. So if a drug that is usually acting more on the thrombotic balance is acting so well on the hyperpigmentation, maybe in those cases we are creating more thrombus rather than sclerosis, as we should. Paul Thibault has all my admiration because in 1992 already was describing techniques by laser to reduce the iron deposition in aesthetic phlebology. So Raoul Jindal was totally right before when he said that we keep on beating the same dead dog. We are always there with the same topic since 1992 and before. When we are talking about metting in met and unmet needs, again, I think it is not true that it is usually transit as reported in the literature. We know that it can happen, and we know that we are in the right place to talk about the feeder vein that has to be looked at to have a proper resolution of this metting. And indeed, this is the man telling this us, with all the due respect for having stolen the picture of Kazoo, with all his techniques that are helping us to have a proper visualization of our target vein. Met and unmet needs. Is it really true that it is so safe? Because there are reports of severe complications after sclerotherapy. But the only one I really had were when I was in a rush to see another patient, when I was mobilizing the patients way too fast, when the patient was putting the compression on by himself or by herself. So when we are talking about evidence and empiricism, you see over here, for example, the recommendations in Europe are to see not to move the patients too fast. But in reality, we know that it should be a super 1A, because empirically we know that that's a very important thing to do. Now, we go back in time. There is a very nice quote by Van der Strict. It's a great phlebologist from the past. He was saying, we should never forget about history, know history. Because if you know history, you avoid wasting your time trying to open doors that were already opened by others. Now, it was 1980 when a French author came out with the different kinds of sport. So when they are asking us, should we do some sport activity? Yes, but which one? Because sport is like a drug. It can be beneficial or harmful based on how you use it. So also in aesthetic phlebology, what is the real sport they can really do, and when can they go back to that? Now, we are particularly passionate in my research group about the aquatic environment. And you live in a country that has some nice beaches as well, so you can use that hydrostatic pressure, but of course, again, in an evidence-based way. So we try to put evidence with scientific publications that you can find available for free on Phlebology Journal also, that are showing how we can have a benefit with a standardized and reproducible methods. It's not just go walking into the water. In Italy, for example, there is the concept to go walking with the water up to your knee. But in reality, you need more pressure, and you can change that pressure if you use thermal water rather than normal water. What about traveling after aesthetic procedures? What do we really know about the risk associated with the different injections or laser treatments that we are doing? This is a nice graph that is showing us how in reality we are maybe underestimating the issue of the thromboprophylaxis after venous procedure. Because in day surgery procedure, what they found is that up to 6 weeks after the procedure, you have a 10 times higher risk of developing thrombosis. So particularly in a COVID time, I think this is a hot topic. As it is hot the sun in terms of sun exposure. Now, I like to ask Brazilian colleagues and friends how you behave in front of a sunny weather that you constantly have and the aesthetic treatment, because in reality we have 2 weeks avoidance of sun exposure in Europe, but with just a grade 1C. I'm cutting short. Okay. And then we go back to Fabricia and the guidelines. I really suggest you to have a look at that document that came out from the winter 2019, because it's pretty fascinating to see the different recommendations we have in the different countries. This is also for favoring lasers versus sclerotherapy. Now, if I dive into the literature, correct me if I'm wrong, but in reality, laser is still not surpassing sclerotherapy in terms of indication. You still do sclerotherapy. If you cannot do sclerotherapy, go with laser. But maybe it's wrong, and maybe we should adapt that. And to do that, we have to move forward from empiricism to evidence-based, and you are exactly in the temple of Clinica Miyake. That is indeed a place that I truly mean it, not just because I'm here, but I truly mean it. Everybody should attend this meeting at least once in a professional lifetime. And that's why I appreciate a lot the effort we did together in putting out this paper that is out there to tell you exactly how Kazoo envisioned the CLACS methods to be sure that you don't have false reproduction. You see over there Darth Vader that is saying basically, I find your lack of evidence quite disturbing, because there is this interesting Cochrane that Fabricia was already mentioning that is indeed pointing out how much work we still have to do on the topic. We cannot really come to any solid conclusion. That's why we are doing this session today. One last comment on peri-procedural activities you can have. Now in Italy there is a lot of talking about carboxy therapy. I don't know if you have it over here, this kind of, which might be helpful eventually. First of all, it's not resolutive, but this should be really stressed out that up to my knowledge there is absolutely no data to really support that. And we are getting the risk of having patients being diverted in some aesthetic center rather than in some real clinic dedicated to real treatments. Because this is a real commercial that is out there that is saying that you can make that vein disappear. You can read what is written in the commercial. After 2 months of topical cream, do not undergo surgical or endovenous procedures, they say. Do not undergo venous procedures. So that's why we got together literally with on the world 69 countries, 83 scientific societies and institutions, and it was truly an honor to have a presentation of IMAP in Dubai, and we look forward for finalizing the document that will be published in International Angiology Journal, together also with a multilingual document available for all the patients. So if you want to take part in that, of course it will be a pleasure to have you involved, as it will be a pleasure to have you involved during the upcoming Vein Week, for which I thank Kazoo to have involved IMAP on this. We look forward for having you in this a typical meeting for just 100 people in Italy, in Ferrara, in our university. But before that, don't forget that you have the honor of having Professor Kursat Bozkurt with you, who will introduce you the huge opportunity of Istanbul. I think we learned after the pandemic the importance of being together, and the world of phlebology is together thanks to the UAP after decades. So I look forward for being all together once again after the historical moment of the pandemic in Istanbul. Thank you.
Thank you. Yeah. And
I have a trick.
Well, you told me that we are. Você pode botar de novo aqui o chroma key? I was explaining to Sergio about the chroma key. That come here, yes, okay, here. Let me go together with you there. Okay. That we were going to do this is not was the experimental way of teaching, and we can also be bigger there. We can go inside of the talk and to do this live. And he said, okay, can you put some hair in my and you can make it younger? Well, I can put you a IMAP hat, like a custom-made IMAP hat, yeah. Wow. And I will join you.
I love it.
Yeah.
Oh. So you want
Yes, okay. Wait. I need to just remove the tag, yeah. There is a tag. Wait. Okay.
Okay. So we take a picture.
Then,
yep.
Yeah, look how cool.
let me make it more cool, because that was a surprise actually, but then I was bringing my surprise.
Okay.
So since this is quite an historical moment, I would say, we get out from a historical difficulty, and at the same time we learned that staying together, we can take the difficulty as an opportunity. I think these 2 years have been an opportunity to grow together, at least virtually, trying to promote evidence-based science. That's why these are the T-shirts of the University of Ferrara, where I'm waiting for all of you, even if it will be just for 100, so I hope you reserve on time in case. And these are exactly the T-shirts for you, for Bono, for Marcelo, for Felipe, who should come over here at least for the picture, because I like an applause for Felipe once again. Come on, Felipe, you can come also with Bono in case, for a picture. No?
I believe Bono and Grill are at the clinic already.
Yeah,
right?
because I think it's
Bono's
always about
here. Bono, yeah.
I think it's always about the teamwork. So we are used to say that players win games and teamwork win championship. So these are the T-shirts for all the team of IMAP, including also Marzia and the beautiful family that you have. So an applause for the ones who have been working behind this. And here are the T-shirts that we will give to all the group.
Thank you very much.
Thanks
Thank you very
to
much. Yeah.
Now we go back to work.
Okay.
Okay. Now if you
by the way, you can customize your hat at the IMAP Academy. You just go there and buy some patches. There are many types of patches that you can customize. Okay.
Thank you so much. That was really heart-touching. So should we finish with the
discussion?
Okay, so we move forward quickly with another giant figure from Saudi Arabia, Abdul Muttalib Azloum. He really showcased great knowledge during the last meeting in Dubai, and I look forward for the question.
Good morning, everybody. Thank you, Professor Genesini, for the excellent presentation, as usual. My question, we have a subset of patients who, after completion of savinous ablation and sclerotherapy for the superficial varicose veins and small spider veins, they have multiple recurrences despite we doing multiple sclerotherapy sessions. What's your advice? What could be wrong? Second thing, what is your advice also about avoiding or minimizing hyperpigmentation? Thank you and happy conference, everybody.
I think we should talk about the sun exposure, considering the kind of video he sent. But jokes aside, recurrence is actually coming from the first step of the treatment, that is diagnosis. So I keep on saying that rather than asking for new fancy devices to treat the vein, we should ask for new fancy devices to diagnose the vein, because that's clearly from the aesthetic to the therapeutic part, the ones that are giving the recurrences. So first
and by the way, Sergio Genesini won the Hiroshi Miyake Award 2019 with evaluation of diagnosis, perforant veins.
Yes, so the first question, just to go quickly for the sake of time, I think is diagnosis is the first and mandatory step to reduce recurrence. Just to give you an idea, we published a paper in Phlebology 2019 where we showcased the importance of the iliofemoral tract. Having or not a competence above the terminal valve is leading to an odds ratio of recurrence of 4.8, which means that if I cut this room in two and I do laser over here, radio frequency over there, but I don't know if you have an incompetence of the iliofemoral tract, I might conclude that laser is working better than radio frequency, when in reality it's just the fact that you have more pressure on the terminal valve in one group. So that's just to answer to that. Hyperpigmentation, again, I think experience is, first of all, and that's when I see in CLACS a huge potential, because it looks like complex. The first time I approached it was like, wow, that's pretty complex, but in reality, the way it has been standardized by decades now of experience really makes it easy if you learn it properly. With the sclerotherapy, you can have very, very good results, but you have to have a very, very good training. So with this, just to move forward quickly, we fly on the way to China. I don't know, do you know Professor Jin-Song Wang?
No.
You should, because Professor Jin-Song Wang is a huge...
Dear Chairman, very honored to join this program. I have a question for Sergio. You know, people usually do not like to go to the clinic very frequently. How do you reduce the patient's clinic visit to the minimal times during the procedure management? Do you use high technology like social media for patients' follow-up? And is there a concern about this? Thank you.
So if I understood correctly, because the audio was a little bit glitchy, how do I follow up with my patients? How do I keep track with them? Well, I think there is no one size fits all at all in varicose veins. We are more like tailors, I would say. So it really depends on the concept I was saying before of knowing your patients as you know your friends, meaning that based on the history and the genetic predisposition and the environmental factor, to keep track with them. It's always good to answer one time more rather than one time less. I know that many times we are overwhelmed by things and we tend eventually to postpone or not see the patients, but they are trying to communicate something. And I don't think we do just a sclerotherapy, we do sclero and therapy, so it's also a psychological component to be followed with these patients. Now it will be very easy and an honor for me to have the next question, because it's directly coming from the president of the UAP meeting in Istanbul. Kursel.
First of all, for everything. It was a great organization, great invitation. Sergio, actually, I don't have a question to you because you made a wonderful presentation. I mean, I cannot ask you anything, but just comments regarding my experience. The first thing, I'm running a busy clinic. We are doing 25 sclero sessions each day, around 1,000 new patients every year. Unfortunately, still I'm having more than 1 or 2 patients every year having a ulcer. Small, big, but doesn't matter, ulcer. I mean, we are applying all of the rules, slow injection, low concentration, whatever. Every year I'm seeing 1 patient with ulcer, and unfortunately, in a artist, in a rich guy, imperator, something like that, it happens to this patient, and it's really painful. First, do you think some other very nice trick in order to avoid this ulcer business? And actually, the reason I came here, one of the reasons I came here, yesterday I was in the Kazuya Miyake clinic to learn better CLACS technique. And the next point is, you know, this aesthetic business. Turkey is also a hot region, and still we do have a lot of matting and also some hyperpigmentation. So the problem is, in order to reduce this kind of things, we should have something more. including CLACS. Do you have some tricks to tell us?
Tricks, sorry, but with the audio is a little bit difficult. To reduce hyperpigmentation and to
And
reduce
ulcers.
ulcer recurrence.
Ulcers, it's correct.
Skin ulcer after sclerotherapy, do sclerotherapy.
Well, honestly, in my experience, the answer is extremely rare. So again, a proper assessment of the patients is mandatory in situations like this. I think that devices like high-frequency ultrasounds might help. Maybe these are patients with microfistula that can predispose to the condition, because either it is a paravenous injection or it is an intraarterial injection giving that, or wrong concentration, which is not your case, of course. So the only thing I might think is maybe you have a microshunt that is creating the situation. Maybe there is a malformative component in these patients that we don't take into consideration. So I would just try to assess properly if that specific patient has some arterial component as a shunting situation. In terms of hyperpigmentation, I can just give you empirical facts of mine. Since I started using a cream, a topical, that is an iron uptaker, so I gave it 1 week before, and for all the time of the treatment, I noticed better results in this sense. And for sure, I see far better results when my patients are going into the aquatic environment. That, of course, cannot be the suggestion of sending everybody to the pool, but is the suggestion that proper compression might help in the containment of the inflammation process that is leading to the iron release. That does not apply those to CLACS, so I would be interested to see if in CLACS it makes sense or not to focus that much on compression as I do. But we focus a lot on the activation of the muscle pumps and the related compression. So that's not a minor thing, I would say, in the management of the patient.
May I add something? We've published the role of viscosity in avoiding the skin ulcer due to sclerotherapy in phlebology 2012. It's my father's PhD, which when I started going outside of Brazil to Congress in 1990, I saw that no one knew about this PhD, and I started to translate it and to publish, and it took me 20 years to publish the PhD thesis from 1972, and with the Ted King. Helped, was the only solution when I was always quitting, I quitted to try to publish, and then I joined him, he joined me to publish, and in that paper that we have on the website as well, it shows that the viscosity plays a great role in avoiding. As soon as you start claxing and you start using dextrose, 75% or 50%, your cases of skin ulcer will go to zero. You will see. In my life, I never had a single one because I've never injected detergents. When we were publishing this paper in 2012 in phlebology, we found a paper where the doctor, I believe in the US, I don't remember the name, was evaluating microshunts, and I don't agree. I really don't agree. I believe it's the theory is that when this patient arrives at the day because she's a lawyer, she doesn't have time, and she's worried about the tiniest vein, and then you go with a 30G or a 32G syringe in a tiny vein with no outflow, and sometimes you puncture the vein and you don't know that telangiectasia, where's the blood direction, and maybe you punch that vein in the opposite direction, pushing, and you cannulate the vein because the vein is so tiny that you don't allow the sclerosing agent to go to the normal vein flow. And then you push, really push with almost zero pressure, as you said. You remember that you're trying to do as less pressure as possible, but you push that sclerosing agent to the capillary system, and probably this happened many times, but in that patient, there is a strong reaction and contraction and coagulation of the capillary system, and that's why the skin ulcers are so painful, and they create a big in 1 week or two. I never saw, but I've seen descriptions of that, and I've seen cases as well. The big hole, second intention healing, and That's the way. And about pigmentation as well, the Clax technique, it really causes this internal diameter to reduce, and the only compression that we use is a adhesive tape with a cotton ball, stay there 2 hours, and this cotton ball, after 2 hours, when we remove, you see there is a dent on the skin, and we allow the patient to go back to the gym and even to go back to the sun.
Good. So we move forward for the sake of time, and we have Carlos Simkin from Latin America with the last comment. I think it's recorded.
Hello? Hola?
Is he with us live?
Yes.
That's
I
fantastic.
made it.
Hey.
Hello, everybody.
Ciao, Carlos. So nice to see you. President of the Foro Venoso Latinoamericano. Thank you for being with us. Any comment, question?
First of all, I'm very happy to be here with all of you. Kazuo, congratulations for the Congress. And Sergio, thank you for the invitation. Excellent talk. I will not make you a comment. I will give you a comment. Very procedural management is very important, starting with informed consent, continue with an ultrasound, a detailed ultrasound, lay down the patient, see the reticular veins with the patient laid down, and continually explain to the patient what you are doing. If you perform claps, it's okay, great. And if you don't have the laser, you perform sclerotherapy. In both cases, inject liquid very slowly, very kindly, and explain to the patient what are the side effects that maybe the patient can occur. We do not indicate indications of resting from any kind of procedures, and in class C1 we do not use elastic compression after the procedures. And regarding for traveling patients, we perform claps and we perform some other procedures. We indicate in that cases ASS, acid acetyl salicylic, 250 milligrams to avoid some complication during the flights. Thank you, this is it, and enjoy the rest of the...
Thank you so much, Cass. Just one quick question then, since you just made a comment. Do you use compression, and for how long after aesthetic treatment?
We do not use compression after
You do not?
No, we do not use. Only we use when some cotton and stitch, extended compression for 40 minutes, and that's it.
Thank you. That's surely another gap we should discuss. So with this, we go toward the conclusion. We should have just a final... Thank you so much, Carlos. Looking forward for seeing you in Argentina. Thank you.
Thank you. Goodbye.
Then we move forward with the last comment from Professor Tessari, because, of course, we all know Lorenzo Tessari, we all know the methods, and it truly is another master in the field. And I think it's particularly meaningful to have the message from him, considering this is the temple of Clax that can totally collaborate with the world of sclerotherapy for a proper aesthetic management. You should have a video.
Dear all, it's a big honor and a pleasure for me to be here with you today, even if only virtual this time. I would like to congratulate Professor Miyake deeply for the understanding result for this 10th edition for IMAP. Aesthetic phlebology is the highest form of phlebology. It's not about training just some spider veins. It's about knowing the depth and the superficial system and making sure all is properly set for the right treatment of the aesthetic complaint. A lot is still empirical, and learning from a master like the one of the IMAP is crucial. I also encourage the new generation to investigate more on this very important topic. and gaining the top expert from the field for appropriate converting, involving both sclerotherapy and laser. With all my admiration for the IMAP team. Un abbraccio dall'Italia.
And with this meaningful, I think, greetings from Professor Tessari to the IMAP world, we go toward the conclusion. You can share the last slides that were meant to be used when I was giving the surprise present to Kazoo, but I had to use it before. As I said, in life, it's not just where you're going, but also whom you're traveling with. So it has been a huge pleasure. If you want to advance once again to travel all together, there should be another slide, if you can advance. If not, it is. With all the friends of IMAP, of course, I don't have the pictures of everyone, but I look forward for taking many others together here in the rest of the world where we'll meet. Thank you so much to all. We have now a session that is dedicated to clinical practice, so there will be the chance of having questions from the audience also about this session during the discussion of the case. Okay? Thank you so much to everyone. Thank you.
Bravo. Oops, sorry. Thank you very much, Professor Gianesini. That was indeed a very special session. And we know we are a bit behind the schedule, but of course, with such a tour around the world, I mean, we couldn't just, be kept for time reasons, right? So we hope to catch up in the next session. We are going to break for coffee now. So take your time to relax a little bit, do some exercise, do some, calf pumping so that your blood can start circling again. Have fun, do some networking, and we should be back in 15 minutes to enjoy the live session. Thank you.
Já vai caindo e o seu olhar parece acompanhar a cor do mar. Você tem de ir embora, a tarde cai em cor e se desfaz. Escureceu, o sol caiu no mar e aquela luz lá embaixo se acendeu. Você nós dois, sozinhos nesse bar à meia luz, e uma grande lua saiu do mar. Parece que esse bar já vai fechar. É sempre uma canção para contar aquela velha história de um desejo que todas as canções
porque eu não sou muito familiarizado onde é que são os botões do laser, pode ser que eu fale alguma besteira se eu quiser me enfiar a falar alguma coisa.
Eu já deixei.
Larissa, Bono. I can see also Fabricio, Professor Cursat, Sergio is coming. Hello.
Danilo, abre o nosso microfone para a plenária, por favor.
Hello.
Hello.
Hello, Marcato. Hello,
Are you
group.
listening? Hello.
Hello, you are listening us?
People are still returning from the coffee. Just 1 minute, please.
Thank you.
Don't worry, Bono.
Danilo, volta a imagem para nós da plenária. A imagem da plenária.
Não, agora deu certo. Agora já está transmitindo. Só tenta jogar o feedback da imagem da plenária aqui pra gente.
Ótimo, obrigada.
If you could start right now if you want to explain what we're going to do and the case, what your strategy of treatment right now.
So here we are in the Clínica Miyake, in the main surgical theater. We have here, please change for the Danilo, muda para a câmera de cima, por favor. You're gonna see here some reticular veins connected with some telangiectasias, and our purpose is to perform claques in this area.
And
let's see with the augmented reality. Here we can see the reticular, the feeder vein, connected to the center of the lesion, and also here some small branches.
And have you seen the ultrasound? What's the diameter of these reticular veins? Group?
Yeah, we performed the ultrasound examination before, and they are something about 1 millimeter. 1 millimeter. We have a... So, let's start, Gustavo.
So, Okay, Bono, now I'm going to propose to do the CLACS technique here with the augmented reality, the EasyVan, the equipment I use it every day in my clinic to identify better the lesions and can do the laser treatment on the target. We are going to use the X-rays. We prepare with the CLACS parameters with a spot size by 6, 70 joules, and the interval to 15 milliseconds. Now we are going to start the treatment of this area.
Without glasses.
Oh, thank you. I'm going to put my glasses
Danilo, abre para a câmera aberta, por favor, plano geral.
here. And you go try to the lesions. It's important to do the laser pointer to
Pode
90
cortar para a
degrees
câmera de cima.
in the lesion and use the cooling device. We are going to this aspect. It's sufficient to do a small contraction and this low flux on the area. And another this one. So you can see what is the laser aging on the vein. It isn't necessary to take out the image because now you're going to do the cryoscleral with the stenosis. And like Kazu said every time, it's only need to cook the vein. It isn't necessary to explode the vein because the CLACS is very secure to do with this equipment. Pode vir do lado de cá. Now you're going to do the cryosclerotherapy. On the veins. And you can see the glucose going to the veins. Another one. Now you can see stopping the flux on the vein. You're listening to me, Bono? After you take the needle and going to do another area to finish all this lesson.
And are you shooting the reticular veins and the telangiectasias at the same time? What's your strategy plan right now?
Sorry, I can list it new. Can you repeat, please? And here we stay with this aspect. The main vein is straightened. And the telangiectasia is going out. You can do another one, cryoscleral here. It's succinct. And now we can see, so with the augmented reality, don't have more the image of the vein in this region. Okay, Bono?
Can you hear me?
Yeah.
Okay. Does anyone here have any questions to Marcato about this procedure?
Now we are finished with small bands and take this off 2 hours and go out to the home and take out and don't have to need anything more.
Gustavo, can I make a question to you? Can you hear me, Gustavo? This is Sergio.
Yes, we are hearing you.
Yes, Professor.
Perfect.
So out of 10 times, say that you get out of the veins at the beginning of the experience 3-4 times, I would say. Is there any complication you see in injecting dextrose outside the vein?
Teacher, so many times when you do a very small volume of glucose and it's one that times we use glucose because go out the vein, don't have so many problems in comparison to polydocanal, for example.
Yeah, that's a major point that I like to raise indeed. So how to manage eventual complications if there are any when you are injecting outside the vein.
Do you have any scars and bruises and complications with the injection of dextrose outside the vein, Gustavo? That's our question here.
No, não vi. Now, with these parameters, it's very difficult to have some complication because these we use glucose 75%, and you go to a small volume or outside the vein, don't have some problem. But if you do very volume, so many 2 ml, 0.3, it can be a scar. Have you done the thesis that can you inject glucose on the vein, outside the vein, you don't have scars in comparison of the other medications.
Thank you, Gustavo. Does anyone here have any question to Gustavo? You can continue the procedure, Gustavo. We are watching here, and if you have any questions, we ask you, okay?
Okay, Bono. Pode virar mais pouquinho. Aí. We turn off the laser because don't have sound here.
Do we have any other questions from the audience?
Bono, you listen to me?
Yep.
If it's okay, the image, and don't have many questions, we have the other case.
Yeah. We have another question here, Gustavo.
Gustavo, not to torture you, but just to keep the discussion alive and hot. When we do sclerotherapy, at least empirically, I have the feeling I have to be particularly cautious in the posterior region of the thigh where the patient is spending potentially a lot of time sitting. Do you have the same concern in CLACS, or the fact that you don't have strong inflammations from sclerosants is not really making a difference for you?
Bono,
yeah.
O som está muito ruim aqui. Se eu puder repetir para mim.
He asked if you have any concerns about this posterior region of the thigh, because the patient's always sitting down after the procedure. If you're using dextrose, you have any recommendations or any concerns?
No, I don't use like the protocol of Clínica Mayaki. Use only the band-aids and the patient can do the normal life.
Okay. So if you have any, we don't have any other questions, we are going to move on, okay, to the presentation. So I will ask, do you want to say any other words, Gustavo? Any final words for us?
Okay, it's a very safe procedure. You can do this with some equipments. I use this for 3 years in my clinic. So last year, 1,000 case of CLACS. It's very secure to do.
Okay. Thank you, Gustavo. So we are moving
Thank you,
on.
everyone.
And I will ask Fabrício Santiago. He's going to present a review of his Hiroshi Miyake Awards, which we are 2019, if I'm not wrong. 2015, sorry. Hello, everybody. Did everybody had a cup of coffee? Because we start now to get tired, and we want to listen something that can bring us something to our daily practice. So this guy is going to say something about a prize that he has won, but this prize has turned on a paper, and this paper probably are going to give you some information for your daily practice. I was watching one of Professor Hiroshi Miyake's presentation when I was a resident here in São Paulo, and I was amazed about his presentations, and when he kept telling that we need to spend more time with the patients, we need to examine patient, and his lectures were a few when we were talking about aesthetic phlebology. After that, Kazuo continued doing his work, and it's impressive how he managed his operating theater in terms of delicacy in performing phlebectomies. Of course, I didn't have the experience of seeing him live, only some videos, but he was an inspiration for continue doing, at that time when I was a resident, for investigation some things. I have no disclosures for this, and this is how everything started. I started watching the presentations and asking some questions about the things that were presented, especially when I was watching a very huge figure there telling in my huge experience, in all the cases that I have, and I was trying to understand how without experience, I was a junior back then, how could we give that information consistency? So this is how I started to perform some investigations after quite some years, working only. And in 2011, the first IMAP, it was not IMAP at that time, I was showing my first investigations. I was comparing the pain between transcutaneous laser and sclerotherapy. After that, I presented results using dextrose in varicose veins, not only reticular veins, and by showing the importance of photographic documentation, this also turned into a paper that is published on phlebology. 2014, I presented an investigation where we compared endovascular thermal ablation with EVLT, 1470 without tumescence. This is something that Professor Júlio Ferreira is master about it, comparing with stripping. Unfortunately, it was rejected 7 times, and I quit it on publishing it. And in 2015, fortunately, I was granted with the Hiroshi Miyake Award, and as I mentioned, it was published on Phlebology Journal. How it started? I'm a vascular sonographer as well, so I perform ultrasound investigations for other colleagues and on my own patients. And I started seeing in lateral and posterior thigh, we had some very interesting images. The connection of telangiectasias of reticular veins with some reticular veins, and we can see up there a perforating vein with a 90 degrees correlation with the reticular vein. So I started imagining, is that common or not? Does that could interfere with my treatment? As you can see here, a very tiny refluxing perforating vein in lateral thigh with a big reflux when you're using the Doppler. So I started investigating this situation, And what we have done was between June and December of 2014, we investigated 24 asymptomatic patients, 43 limbs, C1 patients in lateral thigh, is what we call the Albanese plexus, and patients had telangiectasis in lateral thigh. And another reason that I started doing that is because when you see here, you can see probably a very tiny reticular vein, and when we go down, it's a huge reticular vein, sometimes even a varicosity, not a reticular vein. And if you don't use the ultrasound, you probably are going to inject dextrose or a low-power sclerosant, and you will have thrombus, or you won't solve the patient's problem. So we investigated reticular and perforated veins according to the presence or absence of downward flow time greater than 0.5 seconds. And why did I put downward flow? It's because in lateral and posterior thigh, the downward flow is common, is normal, because the Albanese plexus is embryological involution from the lateral marginal vein. So we don't have a small saphenous vein or great saphenous vein. So it's common, it's normal. But what I started seeing, that it was not normal to see downward flow greater than 0.5 seconds in patients without telangiectasis or without reticular veins, even knowing that the flow could go downward. And we don't have the concept about reflux in reticular veins. So this is something that I just put as a parameter. We measured the vein diameters, the connections with perforating veins at the level of the thigh and at the distance. So I started searching for the reticular veins and seeing where was the point that the reticular vein was re-entering through the deep venous system. And we made a correlation between BMI, current use of oral contraceptives, and history of pregnancy. And especially the BMI, I was starting seeing patients, obese patients and overweight patients, and seeing that these patients had bigger reticular veins. But I couldn't prove that. So I compared these patients with telangiectasis with patients without telangiectasis. They were all my patients. And as we can see here, as I mentioned you can see here a very small reticular vein in a patient without telangiectasis. The reticular vein was there. And you can see that I was doing the compression, and there was no downward flow or reflux. So from results, all 43 limbs had reticular veins with a reflux time greater than 0.5 seconds, underlying telangiectasia sites. And this is very important because we have different patterns of combined telangiectasis, and you can remember that we have the upward foliage from telangiectasis draining to a reticular vein, and sometimes we have the downward foliage, and these are some hemodynamic concepts that people from Shiva, Sergio is an expert in that. We need to think about that. So why does that occur? Is it normal? Is it normal? We call the feeder vein once the telangiectasias are upward. It's not common. So this is a bias of the paper because all of these patients had upward foliage. So we should compare it with the downward foliage, of course, and doing the different maneuvers of emptying these veins. And a very interesting information was that, 60% of the patients had the perforating veins connecting the reticular veins at a distance in the lateral knee or the lateral leg. But some patients had the perforating veins directly connected to reticular vein at the minimum distance of 2-3 centimeters. So what could this tell me? I was treating a reticular vein associated with the telangiectasia, and below that there was a perforating vein. So usually it doesn't work because it's just like a sink. You were injecting and the sclerosant is going away. probably was going to work, as Kazuo said, once, 2, 3 times, or by using foam to close totally the vein. And there's a theory that Professor Hiroshi Miyake mentioned, and it's very interesting. And he mentioned that when we are doing sclerotherapy, we don't have control of where the sclerosant is going. And we know that we have an action of on the endothelium from 6 to 10 centimeters after the injection, and we could cause the migration of a sclerosant agent to normal veins. This is one of the explanations for matting. We have a normal vein just near the combined telangiectasias and the reticular vein that is reflexing, and after that we have a matting. And usually this matting had another reticular vein that was not there. And this is something that you're going to see if you started to doing photographs. So probably Professor Hiroshi Miyake was right. We are damaging these veins. And I have 3 cases where the patients were submitted to sclerotherapy with a few telangiectasias. And after sclerotherapy, they had a lot of telangiectasias. And after performing a cautious ultrasound, I noticed 90 degrees connection with a perforating vein that probably were normal. There was just draining, or there was a difference in pressures between the deep venous system and the superficial venous system that was causing a refractory treatment. But the colleague that was performing sclerotherapy could have damaged the valve that was separating the deep and the superficial venous system, so it caused a problem. And what we saw also was there was a correlation, a statistically significant correlation between overweight and obese patients with greater reticular veins diameters. Yes, these patients had bigger reticular veins when compared with patients without overweight or obesity, more incompetent perforating veins, and the perforating veins diameter were bigger than the patients without overweight or obesity. So, lower limbs with telangiectasias, in conclusion, the results show that higher frequency, there was a higher frequency of total perforating veins in this pattern of patients from both competent and incompetent, higher frequency of incompetent perforating veins with a statistical significant difference. And this is what Albanese has described, and you can see that it's not there, but it was in 1969. He was a genius because at that time they didn't have ultrasound, they only had dissections, and the treatment that he was doing at that time, he was using a tube, using an incision, and he was just doing just like SEPS, the endoscopic perforating ligation. He was destroying all these veins with this mini incision, with this tube, to treat those reticular veins. But you can see here that he has already described the connection between the lateral thigh reticular veins system and with the deep venous system through the muscle veins and through in the thigh, at the thigh level of the thigh, the femoral vein, the profunda. And one of the inspirations that things that we're doing, we've been doing some publications, we've been doing some investigations, we continue doing it, is one of the reasons was the inspiration of this good friend. He's one of the guys that is with Gianesini and Bottini in the Wien Foundation. He came here to IMAP and started seeing the results, very nice results, but you guys are doing a great work, but you need numbers for that, for convincing the world that you're convinced, okay, but you need to need data to prove the world that you're doing good things. And this was an inspiration, of course. And it's interesting because sometimes we don't give attention, but we don't pay attention to numbers, but probably nobody noticed the King Kong on the left side, especially the man. So we need data for showing, for proving some things, and probably if I have made a research here, some women I'm not paying attention to the lady, but I'm paying attention to a monkey there. But the men probably were looking at the lady. Thank you very much. Questions or comments? No? So I have a comment. I said something previously on the presentation of VWin, and I talked about performing ultrasound using a high-frequency ultrasound. It's just like using a phleboscope to search reticular veins and using augmented reality to see those reticular veins, especially if you're using transcutaneous laser. Sergio has performed an investigation about that. And I can tell you, you can do the investigation without high-frequency ultrasound. Because this paper was done with up to 12 hertz frequency transducer. It was totally possible, and I can tell you that you can do it with your probes. You don't need to spend money. Of course, you have money you can buy for investigating from some specific cases, but you don't need to do it. The ultrasound that you have is capable by using the best parameters that you have on your ultrasound to see these types of veins, especially if they are refractory. And I was asked once, so do you perform every time lateral tide investigation? Why is that? It shouldn't be better for you to treat, and if you had a problem getting back there, it's just like a flight plan. When a pilot goes to a plane, he knows that he's capable of going from one point to another, but there is always a flight plan for that, for seeing the weather, where he can make a detour for that. In my opinion, this is what I've been doing. So if I have a perforating vein below the treatment area that I have, I'm going or to avoid it, or I need to shut down that perforating vein. How? Depends. Sometimes with foam. I'm not any foam, just like a zoo. I just do in just a few cases, or performing phlebectomies. And it is important, and it has minimized my cases, especially of matting. I continued having some times, but nowadays I have less matting when I perform this type of ultrasound investigation.
Fabrício, when we have a Albanese plexus full of telangiectasias, sometimes we have feeder veins and draining veins. I'd like to ask you a question. Do you close all the feeder and the draining veins because it should be cause matting? Or do you prefer to treat some like hemodynamics principles? Okay.
Yes. There's an Italian guy, I don't remember his name, but he also performs the investigation only by doing the maneuvers. He's putting the leg upward. What is his name? I don't know. He keeps telling that the problem of the upward foliage draining to a reticular vein, it's because of cellulitis. Because the telangiectasias don't have a place to drain properly, and they are going to drain to a reticular system that is going to be overloaded, and the problem is just like Sergio said, probably carboxytherapy. I don't know if it's a guy that are doing that, but this is a hard question. One of the things that I've been doing when cooling the skin with the air cooling, if the vein don't disappear, probably that vein is it's not normal. When you perform the air cooling, the vein disappears is because the vein wall is normal. So be careful with that.
The augmented reality, this is one of the problems because you see too much. And maybe it addresses you to treat too much. Diameter, maybe up to 1.0, 1.5 millimeters, probably this vein is not normal. And one thing that we don't know how to explain probably is the hemodynamic effect. It is the connection of these perforating veins with this system that is draining downward. Probably the patient during her life or his life is walking, and there's a pressure difference between this downward flow and the perforating system with the muscles. This is one of the explanations. It's probably hemodynamic, and it's another overload of a system that is draining downward along with the genetics. So there's a connection between everything. Okay? Thank you, everybody.
So now we are going back to Kazoo Clinics, and we're going to perform a live procedure, laser endovenous laser ablation, live procedure. Kazoo, are you ready?
Can you hear me, Bono?
Yeah, can you hear us?
Yes.
Okay, so I will present the case. It's a 29-year-old lady, and she performed surgery, a microfibrillectomy 10 years ago. And after that, she performed some sclerotherapy with dextrose, 75% dextrose, and foam with the polydocanol. And she still has some telangiectasia that didn't go away. So, Gril, can you show us the ultrasound examination? Tá aí o... Pede para passar o vídeo. We have the video. Kazoo, can you hear us?
Yes, I can hear you. Can you hear me?
Yeah. We are going to show the ultrasound examination before you start the procedure, okay?
Okay, perfect.
Do you wanna talk about the case?
Yes, there is a lesion here. Laying down is not so important, but with the augmented reality you can see. And it's really a dark spot in her leg. She's young and beautiful, and she wants to expose her legs, and she's really not happy about that. And we are going to treat the saphenous vein reflux. There is a perforating vein here, and the saphenous vein is almost duplicated in this segment, and we are going to clax all those lesions here as well. Bono?
Yeah, I'm preparing the ultrasound examination we're going to show right now. Just 1 minute.
Okay.
And are you going to start with the endovenous laser ablation or with clax, Kazoo?
Okay. Tem gel aqui? Tem gel? Isso aqui. Tá. Deixa aqui.
Put it somewhere.
Bono?
I can.
Kazoo, we are showing now the case, so this is the complex
okay, I can see you.
In the room, yeah.
And as we can see in the ultrasound...
If I have to. I don't want to.
Okay.
But if they force me, it's okay. But if not, I'm okay. Okay.
So she already performed a phlebectomy 10 years ago and some sclerotherapy with dextrose and polydocanol. And at the ultrasound, we can see a small saphenous vein reflux, and all this reflux is draining to a specific reticular vein right below the telangiectasia. So, yeah, you can see the reflux, and Marcelo is going down with the ultrasound, and we can see a drainage into these reticular veins right below the telangiectasia. So what we are going to do right now is CLACS procedure in this telangiectasia and endovenous laser ablation of the small saphenous vein. We are back to you, Kazu.
Pardon?
We are back to
CLACS? May I start the CLACS session here?
Yes, please.
Okay, we have two cameras, and I'm going to start. As always, I put the augmented reality to mark where I am, and I'm going to do the first, second, and third pass with the transdermal laser in all those veins, okay? And I'm setting the laser here for 70 joules, 15 milliseconds. Pulse delay, 6 millimeters, but 70, 15, the traditional setting for me. And the laser is turning on. Fluid 70, okay. Always when I begin, sometimes I shoot, I search for a hair, and I shoot on a hair. Of course, it's very small detail here that you cannot see, but I always shoot to see the laser reaction. It's burning the hair, and because this machine is not mine, I always like to test first. And then I'm holding the trigger and I'm shooting continuously. On the bigger veins first, but you can start with the smaller veins. But I like to start on the bigger veins because if you start shooting the smaller veins, sometimes you have a contraction of the bigger vein, and I want to be able to cook all the bigger vein. Then I go on a sequence of shots on the top of the vein, and following all the veins that are inside of this area. As you can see here, I put a mark on the side with a white makeup pencil so that I can shoot in the middle. And I'm holding here the trigger and shooting 1 shot per second, which is 1 hertz. And I'm completing now the first pass in all the veins that are inside. Marcato, can you see how many shots I gave already? Marcato, how many shots? 40? 60 shots already. You see a contraction here, yeah? And I have 60 shots. A good reaction, some contraction, and probably I'm going to go for a second pass only, not the third pass, because I have a good contraction. And now I'm not going to turn on my light because it will be very difficult for you to see due to the contrast, but now is the time that I would turn on my light. Like, I'm just going to do this just to see how it is. I turn on the light to be able to see the telangiectasia through the vein viewer image. And now I'm focusing also on putting a second pass on all telangiectasias. $90. Okay. I'm using 70 joules, which is not much, but I could even use 80 or 90, but I prefer to do 2-3 passes and not so much energy. And as I always say, cook slowly the meat, in this case the vein. If you keep playing on the settings for each vein, it would take forever. It would take forever. In this situation, as you can see, I'm using the laser with a setting that is capable for me to go painting the vein, go cooking slowly with no worries about skin lesion, no worries about burning. And now I'm going to the third pass or fourth pass on this bigger part of the vein. Okay, I believe it's good. You have a lot of contraction. Look here and here. Now I'm going to do the sclerotherapy. Sometimes I have two nurses. Well, here, Marisa is going to hold for me. Let's see if you can see. And the alignment to get a vein with the vein viewer, can you see the image of the needle? Okay. The image of the needle needs to be parallel, aligned with the image of the vein. Then you go with an angle because the bigger vein, and you inject. Inject a little bit, and then I go forward, inject again. Here as well. I like to inject a very low volume of dextrose, but several times. I prefer to distribute the energy like this, because by doing this, I can also damage the vein by the needle, cutting the vein. You see, I'm injecting, but the liquid won't go away so easily because you have a lot of vein wall damage. And that's why the CLACS is so interesting, because you have this synergy between the laser effect and the dextrose 75% effect. Can you see here that the vein is contracted as well?
Yeah. It's perfect image, Kazu.
And I'm going, trying to get a vein. Dá para não chutar. Here on the side, every single green image means there is a vein. There was a vein here, the other vein here. Alguém está encostando no vein viewer. Be careful with the vein viewer here. Sorry. Yeah. Now I will remove here, well, let's try this bigger vein as well. Look, I still got a piece of the vein. As another advantage of the dextrose 75% is that I don't have to prior to injecting, and I'm not afraid of injecting a little bit outside of the vein. In fact, I'm aiming the internal diameter, the lumen of the vein, I'm aiming that. But also I'm aiming the vein wall, because if I hit the vein wall, it would be very nice as well. And after I did many injections, I remove the augmented vein viewer, and now I can inject also easier on the telangiectasias. Você tem outra agulha aí? The needle is a knife, and that means you need to change it sometimes. When you remove the needle, the cap of the needle, I always like to do like this. I hold here, unlock, and then I turn and let it fall. Because if I remove the cap with my other hand, I damage the needle, because I always touch, I will touch the needle with the plastic, and that will damage the needle. Then I'm searching for injecting on the telangiectasia right now. You see, I got a good one, but I don't like to inject a lot. I prefer to keep on puncturing and because aqui, ó. I prefer to keep on puncturing and cutting the vein. Okay. Now I finished the sclerotherapy and we are going to start the endovenous laser procedure and phlebectomy, okay?
Okay, thank you.
Marcelo is ready.
We are going to keep you...
Marcelo is ready to paint, Okay.
Does anyone here have any questions for Kazu? So you're going to start preparation for the procedure. Sergio?
Oi?
Kazu, this is Sergio.
Oi, hello.
So any tips?
Hello, Sergio.
Any tips and tricks for different Fitzpatrick type?
Yes, we treat up to Fitzpatrick 5, and with Fitzpatrick 5, I use 40 joules, 20 milliseconds, and always 6 millimeter spot size. For the Fitzpatrick 4, which is my skin color, and this patient is probably Fitzpatrick 2. I would use 60 joules in my case. I lower the energy, the fluence, I have more passes, I do more passes. But one thing is important to understand, that if you have an aesthetic lesion, that means if the patient is complaining about that, and we had a nurse here, which is Fitzpatrick 5, and I have a very nice before and after of her. We could see through her skin. Her skin is darker, but it's transparent. And we could see all the reticular veins, and it was painful, and we treated only with Clax. And that means if you can see the lesion, it means that the laser will be absorbed more by the vein than the skin, even though the skin is darker. We just need to take care, but it will work.
Kazu, can you hear me?
Yeah.
Can you tell me?
Yes.
Can you tell us a little bit more about this case, because it's a very interesting case we discussed yesterday with Peter. He was with us, and the patient has small saphenous vein reflux, and all this reflux drained to a tributary right below this telangiectasia. And the treatment plan was to start with the Clax procedure. And right after this procedure, we're going to perform the endovenous laser ablation and some microphlebectomy. Some would ask us, why would we start with Clax and not we start with the endovenous laser ablation and perform the Clax procedure after or another day? So could you tell us, or Peter could help us in this discussion?
Yeah, the patient is under sedation here in this case, and we always try to do everything that is needed in all-in-ones. That means, why would we lose the opportunity to Clax her leg while she's with zero pain and a very comfortable situation? And then we try always to do all-in-ones, and the patient is willing to pay that and is valuing that. Is valuing that the fact that she will have a faster result. Because if I could, some doctors treat the functional part and then they wait to see if the vein disappear. But I saw a lot of attempts of that, and in most of the situations, the veins may reduce, but they don't disappear. It's like a balloon. When you have a balloon, a new balloon, zero use, it's small. As soon as you blow the balloon and you remove the pressure, it won't return to the same situation. It will be all dilated, the balloon. And that happens with this venous system. This venous network is dilated. Even though you remove the reflux, you will have, there is blood coming from the capillary through the telangiectasias, through the bigger veins, and going to the heart. And then even though you close the reflux, you may have even a worsened situation sometimes.
Thank you. Sergio, could you tell us about this case? In your experience, would you do something different? Because you have some huge experience with saphenous sparing, and it's a very interesting case.
Yeah, sure. I think a good point is to agree or disagree on the fact that we can always do saphenous sparing, first of all. I come from the Shiva world that is usually preaching the fact that you can always spare the saphenous vein. In my opinion, it's not true. If you look at the literature, for example, there is a paper by Kajati that is showing that in varicose veins patients, you have up to 27% of cases where there is a very short trunk, so basically you are not sparing anything. If you have enough run of the saphenous trunk, I think it has been clearly demonstrated also by Cochrane revision that you can approach a saphenous sparing strategy also by endovenous techniques. I will present this tomorrow or the day after tomorrow. So yes, whenever I have enough GSV or SSV to be spared, I tend to spare
you
it.
made great.
But I think more data also in this sense
Peter,
are needed to really
your head.
understand
Do
the
you have
benefit
something
of
else for
that.
me?
You want Snoopy?
Huh?
You want Snoopy or what you want?
Because we are talking about anatomical recurrences in the
You have
literature.
Snoopy, Sailor.
Yeah,
Let's hope they are not just saying something else, just these things. But long story short, there is a nice publication by Bradbury that is showing that it's not just about the anatomical recurrence rate. If you compare, for example, endovenous thermal ablation and sclerotherapy, you are going to have less anatomical recurrences with endovenous techniques. But in reality, in terms of patients' reported outcome, quality of life, the results is overlapping. So we should also decide on what we are looking at as outcome measures.
Thank you. Kazu, are you ready?
Yeah, good.
Marcelo, Grill?
Yes.
Are you ready
Hello.
to start?
Essa luva para mim. Luva.
So do we have any questions about this case? Or okay. Hobson.
Okay. Bono, can you hear me?
Yeah. Hobson is going to ask you a question.
Meu óculos. Meu óculos está ali, não?
Kazu, Robson aqui. Here.
Hello.
I would like to know.
Can I hear?
Yes. I would like to know what strategy are you using to thermoablate this vein, considering the how high is this saphenous junction and the proximity of the tibial nerve.
Yeah. Okay, I can answer. Right?
Yeah. Okay.
Okay.
Não, é isso aí, meu óculos.
So,
Kazu, did you heard the Hobson answer question?
The strategy is to treat the upper third of the small saphenous vein, and it's refluxing continuously this segment. Tá bom. Arruma aqui desse lado. And Peter will show the qual ultrassom que tá? Ah, tá.
Yes, it's very good question because sometimes you need to perform treatment of saphenous vein even below the middle part, and you have to be very careful about that because the nerve is very close to that, and you can practically need to make visualization of it because sometimes there is some kind of variation of the position of the nerve. Right now we are at the lower part of saphenous, short saphenous vein, and at the medial part you can see here that there is also
on the right side. The medial side is the medial part is
I mean,
the
on
right
the
side.
lateral side, sorry.
Lateral side, yeah.
Yeah, yeah. So I will try to make the point here, and this is right above. You see that the vein here, and
the nerve.
A little bit laterally is here right now. The nerve. You can see like a circle, the white circle.
Yeah.
You can see that. So when you're puncturing the short saphenous vein, you need to be very careful. Also, you need to be very careful when you're pulling back the laser outside. You need to stop with firing, with the delivering of energy before you are out of the vein. It means that like if you are in the vein, and you need to stop it before going out. So this is a small situation where you need to be very careful about that, and this one is really a good example. But
But normally the nerve is on the distal third part of the leg, and normally almost all the times we treat the proximal part, and the nerve is in the distal part, the distal third, and we normally treat the proximal third.
Yeah.
And that's what's happening here.
Yeah, but sometimes the saphenous vein is going down.
Yeah, and you have reflux.
And you have reflux all the way to the ankle, and that's why we need to treat the saphenous vein in all his length.
And you need to put a lot of tumescent anesthesia, contaminated, yeah, okay.
We need to put a lot of tumescent anesthesia. And to divide the nerve from the saphenous, separate it, you know. But it's possible to treat it.
But Kazu, I would like to know
I need another one.
about the tibial nerve above the line of the popliteal line.
Oh, okay. Peter.
Yeah?
Come here.
Sorry. Please.
He wants to know about the tibial nerve, not the...
Not the sural nerve, yeah.
Yeah.
So it's always need to put much more tumescent anesthesia to divide the junction also, yeah. But it's not always easy to visualize the deeper part of the tissue. And it's also good if you put the legs on the fingers, then it's a better visualization of the vein, you know, like that.
Quer que eu saia daqui? Tô na frente da câmera, né? Aqui? Desse lado? Vamos lá, gente?
Did you give to my son here?
No, not yet.
Yes, a small one. You can give it. Not to be painful.
Peter,
yes. Oh, okay. Sorry.
Essa marca aqui é a marca da...
Just put the...
Aqui, né? Ah, tá. Yeah, if you want, you can get it in here.
Okay. So I also made a small tips, make a small marks on the skin, and in that marks we can put a little bit tumescent anesthesia, because if we are working under local anesthesia without sedation, it's going to be painful. And those places are given a small lidocaine before, and that's why it's not going to be painful. And I will use these parts, these spots, just to puncturing, not any other one, you know. Okay. We are going like.
Peter, which fiber
Yes.
are we going to use? And do you know this small vein
The 400.
diameter?
400. We are going to use the 400 fiber.
400.
Look now he's. Peter is going perpendicular.
Yeah.
And then you can see the needle. He's
I always
going in and out, in and out.
I always trying to mark the needle under the ultrasound to see the position of the needle. For me, it's always easier to puncture in transversal view, and that's why. So I'm just knocking on the vein. You see that, and that in that
vein
way,
wall. You're outside. You're outside.
Yeah, I'm outside, but I'm just showing you what is the move before I will going to puncture. Okay, and after that, I'm just going in the same direction, but forward, a little bit forward.
And forward with ultrasound as well.
With ultrasound as well. And now I'm inside, making the correction of the position, and we can put a wire. This is a micro.
Micropuncture kits.
Yeah,
really nice one.
Really, really nice.
Really easy, yeah.
Very easy and very good one. Okay, you can put it down. And it's really interesting because in transversal projection, you can easy targeting the vein. Sometimes you need to use a longitudinal projection, but this time we use transversal projection. So Marcel would put the fibers in, and we will show you a visualization of the fiber.
Can you tell us about the fiber that you are using?
Yeah, this
is radio fiber, 400
radio fiber, very tiny and very gentle, but the energy that he is delivering is quite enough for. We have a little bit drops of air here inside, and please, Marcelo, could you put it on the fingers so to show the difference? You see, when I put the patients on the foot on the finger, the visualization is much better than without that. So use these tips always. So a little bit of air. Yes, it's a little bit air, but it doesn't making a problem. So it's just could make a problem because we need to visualize the tip of the fiber, and also need to visualize the entering point of the junction. So if you can make a deeper picture. So right now you see this is saphenous vein. This is those air which we are speaking about, and this is now the fiber is approaching the deep vein system. So we need to be aware: is there any side branches of deep vein system who is going together in the junction with the?
We don't want to close it, right?
Yeah, we don't want to close it, you know. But the anatomical variation in this area is really variable. So we really need to be conscious and aware of that. A little bit caudal or a little bit in the direction of the foot. There is a Giancomini vein. You can see that here. It's in the middle of the picture, and he's going to connect with the saphenous vein here. You know, so we will treat all the way to the down. Yeah. Okay. So right now we are very deep inside of the popliteal region, and we are practically 1 centimeter just above to the junction. There is a several way you can enlarge the picture now. A little bit.
Peter, just a second. I need to see here.
Yes, again. Okay.
It's too deep, right?
Okay. So.
I don't want to go so deep.
Don't worry. So we are here. This is the laser
Tip, okay.
Okay.
But
and the deep vein is here. See, if we want, we can go further. No. Okay.
yeah, yeah, that's
Okay.
good. Yeah, that's what I
So
like.
if you want to be more sure about that, so we can go even go back. Okay.
Peter,
We don't have.
where
You
are
want
you,
me?
Yes.
Where are you planning to start the thermal ablation?
It's
Considering the small
place.
venous junction.
It's the place where we just showed it. It's like 2 centimeters above the junction, above the zero level of the junction. Okay.
Normally, Peter is using a pump, and he's going like this from the injecting parallel to the fiber, parallel to the vein. That's his technique, with a long needle. Our technique that we use, we go transversal to the saphenous vein.
Okay, you see that here?
But by using this, you have less punctures and less hematoma.
Yeah, you see that
Yeah.
circle? So now I'm going inside of that because there is a previously given tumescent anesthesia, just a drop of lidocaine there. And in a circle.
You see, he's going right in the saphenous slot where the saphenous vein is, near the fascia.
Can enlarge the picture a little bit, yeah. Just to be a better presentation.
Essa aí tá muito zoom.
I mean, on the ultrasound also.
The ultrasound?
Yeah, to make the picture bigger a little bit. Okay, so with tumescent anesthesia, it's also very important to see the needle. Where is the tip of the needle? Here. You're always marking the tip
Mais
of
pra
the
cá,
needle.
isso aqui, ó. Não, peraí.
And you see, we are almost very close to the junction.
Apagou. Você apagou a imagem. Você desligou o telefone.
Okay, we need to fulfill it. Fulfill it.
Okay. Okay.
So we are moving further. We are right now very close to the junction, so need to be very.
Peter.
Yes.
It's Albernaz talking. Sometimes the small saphenous vein takes a long trajectory until going deep until to arrive in the popliteal vein. And if we start to make ablation a little far than 2 centimeters, is there some problem about a long stump?
No, I'm always, sometimes the saphenous vein is, short saphenous vein is going in the upper part of the leg and ending in the central vein. It's embryological vein, and sometimes it's existing, and that's why it's also not a problem to treat this vein, So it's just need to be aware that you're not treating popliteal vein or femoral vein. Other kind of veins you can treat also, This is here we have the very nice example of how we can see the vein wall. You can see here the vein wall and to see the fiber. So Kasu, if you can show.
The fiber, I'm moving the fiber here.
Yeah. I'm giving tumescent below the vein and above the vein, okay? So we are making distance, so you can take the tumescent and you can turn the laser.
Let me see. Let me see.
I think it's not perfect right now.
Pode
Peter, it's Kurshat here. May I ask you one question?
Marcelo.
Yes.
Mais profundo, Marcelo.
Peter, if there
Yeah.
is disease, short and long saphenous vein, and if we want to treat together, do you do in the spine position both of the veins?
Yes, yes, I'm doing in a spinal position, both of the veins. I'm not turning the patients on the other side, from the back, from the spinal position. Always because it's easier not to move the patients, So.
We move, we don't.
Yeah.
We move the patient, we get all the team. With 5 people, we lift the patient and we,
Yeah,
let's treat.
Okay. So if you have enough skill, you can do it also from the back. Okay. Right now we can see everything very clear. We can see the position of the fiber, and also what is very important that we can see the vein wall. So why is it important? Because if we can see the vein wall, then we can see what we are doing during the ablation process. The vein wall, also we can see, are we performing ablation or are we not delivering enough energy? Some of you are using the mechanic or robotical pullback device, but I think it's a blind ablation, and I think it's not so good as we can control with our own eyes. So that we developed some kind of approach to the ablation, and we call that ultrasound-guided laser ablation. It means that with ultrasound, we can clearly see what is happening right now. And now
We have the feedback.
we have a feedback.
The reaction, yeah. Much better. Yeah.
Sometimes when you, I will start with the laser right now. Sometimes when you really not see what is happening.
How much energy you want? Fluence? Power?
Power 6.
6 and, okay.
Yeah.
6.
In that case, it's not
6 watts.
important how much energy you're using. It's just important the pullback speed. You see, we're starting with a...
And you can clearly see the reaction of the vein being destroyed by the laser.
You can see practically the line of the ablation. Is it enough, the energy delivered or not? We can also do with much more energy, but the pullback speed will be much faster.
Yeah, when I've seen Peter treating several times, and when he's treating like 2 saphenous vein, long saphenous vein, he puts a lot of energy and he's pulling back much faster.
Kazu, we have a question here from the audience. Can we ask you? The question is for you, okay?
Okay. Where's the question?
Hi, Kazu. I'm Darlene. I'm from Rio. I would like about CLACS. How do you decide how many times are you going to pass the laser on the same vein?
Good question. I normally pass 2 to 3 times, but if I have a lot of reaction on the first time, it means maybe I do only 1 pass. But in general, when that happens, I decrease the energy so that I really want to do 2 to 3 passes. I prefer cooking slowly the vein than using having a lot of contraction, because if I have a total contraction of the vein, it will disappear on the image of the vein viewer, and then I cannot inject on the vein. Sumiu o retorno aqui, viu? Sumiu o retorno. Dormiu o computador lá. Mexe no trackpad, só mexe assim. Isso, pronto. Ok? Turn off the laser, please. Then, all the saphenous vein the small saphenous vein was treated, and now I'm going to start a phlebectomy. I'm going to check what's happening here.
We lost the image here, Kazu.
Which image?
Yours. We are back.
We are back. Marcelo is going to.
We have you again, Kazu.
Yeah?
Yeah.
Okay, then I'm checking the image here. We treated up to here, and the distal part is not treated. This part is not treated, okay? And if as long as I go up, this is the point where the vein is treated, and you can see I'm going, compressing, and you see that the vein is completely occluded. And I'm very satisfied with the procedure, and now I'm going to do the phlebectomy. Well, the phlebectomy contaminou a fibra, Jonas. I like to do the phlebectomy from the left to the right. And here I have 2 points where I'm going to ligate. Be careful with
okay.
And a perforant vein, okay? Then I go perpendicular to the leg, little incision with the blade 11.
Kazu, can you show us your image bigger, the phlebectomy, because we are seeing you crop it, so it's very small.
Marcelo, consegue mostrar essa imagem maior? É.
Good. Can you see the image from the cell phone above you? Yes, thank you.
Is it okay like right now? Like this?
It's a great picture. Now we can see you.
Then I did one incision and I'm trying to get the vein, okay? Patiently, I go fishing and trying to feel the vein, trying not to damage the vein, the incision. And as I didn't find the vein here, I'm going to the next incision. Okay. Next incision. Once again, slowly, I'm trying to feel the vein. And the vein was so tiny that the vein went out in only one try. Okay, there is a segment of the vein here. Okay.
Even if it's so tiny,
yeah,
it's enough to produce those.
Yeah, but you remember that I treated this part with clacks, okay? Then when I tried to remove the vein, probably was damaged here, and it went out and so tiny little vein. Well, then no problem. I'm going to the next incision here.
Kazu, we are over time. Do you have any final words, any final consideration for us before we finish here?
Okay, well, I'm going to, as soon as we finish here, I'm going back to IMAP. Look, like I got the vein, and we can discuss a lot there as well. Continue this discussion. Here I got the vein. I don't want to cut the vein. I want to make several incisions and keep getting the vein and without without the rupture. Look here, it's very tiny, but we consider this vein a little bit bigger for clacks, and then we decided to do the phlebectomy. But probably this vein could react for clacks, and when we are with sedation, we also not only perform the clacks, but after the clacks, we perform the, we cut the vein as well after clacks when it's under sedation with the needle. Yeah. With a bigger needle, we cut the vein. But here, in this situation, the vein is here. I fish the vein here. I don't want to get the vein like this. I want to get only the side that is going to this direction. And then I do with a gentle massage, and I'm going to change the clamp so that I go slowly and patiently removing all the vein.
When I see how Katsuo is making incision, I notice that he is making incision by taking care about the marks, Katsuo, on the skin. Because if you are making incision through the marks, you can make a tattoo also.
You may cause that as well. You may cause a tattoo when you... O que você está procurando?
Kazu?
Pode começar, ué. Okay, what time is it now?
It's past 15. So do you have any final comments, final considerations for us before we finish here?
I believe if you look here in this camera, if you look this camera, you see that the lesion is practically gone. You see, look, I'm cleaning here. See, watch the difference. What we have now, it's a very good aspect, and we believe that it's going to be a successful treatment.
Already.
It changed already a lot. And also a final thought here is always when I can, this vein is too tiny, I like to ligate. I ligate, if you watch my surgery, I ligate a lot because I want to have zero hematoma or the least hematoma possible after the surgery, and that means ligating all the tributary veins. Like here, the vein is really small, but if I can, I get a thread and I ligate. That's it. Okay?
Thank you, Kazu. See you.
Thank you very much. See you soon.
See you.
Bravo. Thank you very much, Dr. Kazu. So, wow, what a day. And I have to tell you that you were awesome as an audience. It was a long day. We had a wonderful piano performance this morning. Then we had the Chili Bean success story, the virtual sessions. It was incredible. And then to finish...
Nada.
Sorry, guys. And then to finish, we had this deep dive into the live procedures. So thank you very much for your kind attention. And it's time for us to chill out and relax because we have much more tomorrow. So take care, stay safe, and we shall see each other tomorrow at 8 a.m. sharp. Wow. You see, Dr. Rodriguez just told me that we have carnival this evening. It seems that we are going to have a party. So again, take some breath and relax, and then we are going to party later. See you guys. See you tomorrow. Is it? Okay, I was told that the carnival starts now.